Good morning, guys. My name is Arya. I'm a student and I am studying mental health this semester. Today, I'm going to be writing a reflective journal. So, you're more than welcome to study with me virtually. I'm also going to be having breakfast this morning. So, you're probably going to see me eating breakfast from Dunkin'. I love their strawberry refresher. I got a medium ice with coconut milk, which is my favorite. And so I'm going to be doing some virtual study today. Also, I wanted to say that it is my journal that I'm going to be working on today. I'll be talking about it as I work on it. So you guys will hear a little bit about what I'm writing about in my reflective journal. So I'm about to start studying, guys. Hope you all are having a good day. I pray that no weapon formed against you shall prosper. May God put a whole armor of protection over you from the crown of your head to the sole of your feet. I pray that you'll prosper, you'll be in good health. I pray that Jesus Christ will deliver you from those who will try to stop you or seek your demise. I pray that God will allow the Spirit of the Lord to be upon you, that He'll save you, and that He'll show you that He loves you. He's a good God, and He wants the best for you. So I pray all those who are studying will pass their test, that you guys will get more knowledge, wisdom, and understanding. You'll understand the rationales, the concepts, and that you'll be able to save patient lives. If there's any, you know, anyone can save a person's life, but especially you can. All right, guys. Shout out to Bulgaria, Unexpected Wonders by B. Vigaria Romeo. I've been saying y'all when God blessed me with a husband, I was like, babe, I want to go to Paris. I want to go to Rome. So I would really love that. I would really love that. I would really love to go to Rome or Italy or Paris. I think I was saying that um, there's a really good communicator, Jenny, and she's married to Jeezy, and they just had a baby. And this lady has so good communication skills. Let me see her name. I mean, she talks so fluently, which is so great. They're married. I think they also got married, or they had their honeymoon in Italy or Rome, which was so nice. Her name is Jenny May, Jeannie Mai, and she's a host. She just welcomed her first child in January. Their daughter name is Monaco, Monaco, and I just think she's so nice and just so like great personality, and I just wish her the best for her marriage. All right, guys. All right, so let me get started here. I'm gonna be studying with Wu Jin Chao. Okay.
New Thicket Sticket Thickening Brow Gel Mascara with vegan plant-based fibers and 16-hour hold.
All right. So my reflective journal that I'm going to do today is going to be, as I'm waiting. All right. So my reflective journal, write a brief discussion of what you learned today. Describe something that you saw in the clinical experience that is exciting to you as a health professional. In what ways has this experience challenged your assumptions, prejudices, or biases? What perceptions mean or understandings gained today? What did you learn today that applied to previous or current lectures? What did you learn today that you'll be able to use in the future? What areas you did well in, and what areas you would like to improve? And what are your goals for next clinicals? So my focus today is going to be on Maslow. So let me see here. Let me see. Probably Maslow is probably going to be. I'll take in pharmacology. I'm gonna check. I'm thinking like med surge. So I'm not seeing anything in this book here. Let me check my med surge. I know it's probably gonna be in the foundations. All right, so I'm probably gonna have to get my foundations though. Okay. All right, guys, I'll be right back. I gotta get a book. Right back. All right. Okay, guys, so I'm looking for Maslow, my fundamentals book. Okay, so it's going to be in the nursing process. Okay, so if I'm looking for Maslow, I'm going to be wanting to look at the nursing process. So let's see here. It's chapter 1. Okay, but I'm not seeing it in this one. Okay, I'm gonna see if it's in our medical search.
You founded your kayak company because you love the ocean, not spreadsheets. You need to hire. I need Indeed. Indeed, you do. Indeed Instant Match instantly delivers quality candidates matching your job description.
Okay, guys. All right.
for real happenings, real excitement that lights up the night brighter than ever before. Ignite your summer from day to night, all summer long during Electric Ocean, with annual passes starting as low as $14.75 a month. SeaWorld Orlando, real amazing. You coming or what? moisturizer with clinically proven soy. And the tone and texture are back.
Hi, good morning, Margot. My name is Aria, and I was calling to ask if you had any openings today. You can give me a call back or send me a text, please. 321-417-4744. Thank you.
Journal Daily Bread June Ishum registered nursing student Terry Allen. Entering the clinical was a picture of a man sitting down, looking sad, tired, defeated, and in poverty, a potential begging man.
Anne. Next to him read the words love and Reflective Journal Daily Bread June 4, 2022 registered nursing student, Aria Allen. Entering the clinical was a picture of a man sitting down looking sad, tired, defeated, and in poverty, a potential begging man. Next to him read the words love and acceptance with the author's name Maslow. I gained and acquired knowledge on the study and experience of Maslow and how this painting had a mutual relationship with the clinical being established. Maslow hierarchy of needs are in need of importance: physiological needs, safety needs, love and belongings, esteem, and self-actualization. Physiological needs gives an account of air, food, drink, shelter, warmth, prayer. Safety needs are characterized with the protection elements of security, order, law, stability, and freedom. Love and belonging is represented by friendship, intimacy, trust, acceptance, receiving and giving affection and love. Esteem needs represent esteem for oneself and the need to be accepted and valued by others. Self-actualization needs is the realization of the personal potential, self-fulfillment, personal growth, and peak experiences. McLeod, 2007. As a health professional, I had a strong feeling of enthusiasm and eagerness to see that the Daily Bread did not want the people to stay poor. Maslow physiology needs were activated and the people were given clothes to put on in exchange for their dirty clothes so that the dirty could be washed. The opportunity to take a shower and be supplied with body wash, conditioner, shampoo, deodorant was. Self-actualization, esteem, love and belonging. Safety needs, physiological needs. Given, if a client need new shoes, they were given shoes, and if they had any mail, they were also given their mail. I was given a rise to the theory of Maslow to focus on physiological needs. This clinical experience has given me a call to take part in my own perception of an experience and not the expression or application of human creative skill and imagination. As I entered the Daily Bread, there was a paint of a poor man wanting to be loved and accepted with the name Maslow. It is important that people are not accepted as being poor. It is important that people are not loved at being poor but loved out of poverty. Yet the principle and standard of actions and behavior to get the people out of poverty and into wealth and riches needs to be practiced daily. I also gained more knowledge of the great significance of asepsis, the absence of illness producing microorganism, ATI Fundamental 2019. The poor must wash their hands and protect themselves from diseases. This will allow them to have infection control from bacteria, viruses, fungi, prions, parasites, virulence, and herpes zosters. The skin is the first line of defense against pathogens, and the poor must learn to protect their skin. What I became aware of today is that safety from injury is needed due to the cognitive, sensory, and emotional state. There are many people in poverty who do not have the ability to communicate due to the side effects and adverse effects of the mental illness, drugs, alcohol that has affected their life and safety. As a nurse, I have a desire to encourage clients to speak up and take an active role in their healthcare and in preventing errors. I desire to create a culture of checks and balances to avoid errors when working with clients. I desire to use protocols for responding to dangerous situations. For example, the weather was very rainy on clinical day. Clients were going in and out of the door, possibly unaware that the floor was wet. I understood they were at an increased risk for fall and took action to prevent the client from falling. Next, I would like to improve in ergonomic principles when working with clients to focus on comfort, safety, and efficiency when working with clients. Ensuring that I am using good body mechanics by lifting, bending while assisting the clients in their activities of daily living, ATI. Fundamentals 2019, ensuring that I am aware of the facility's policies and procedures. My goals for next clinicals are to continue to promote health and disease prevention. I want to encourage the client to exercise and have good nutrition and participate in activities that will prevent disease. References: Assessment Technologies Institute, 2019, Fundamentals for Nursing, 10th ed., McLeod. 2022 April 4, Maslow's Hierarchy of Needs, https://www.simplypsychology.org/maslow.html#. Text equals their percent 20 or percent 25% 20 levels percent 20 inches. Esteem percent 2C percent 20 and percent 20 self percent 2 actualization.
Counseling. Basic level psychiatric mental health registered nurses use counseling to reduce anxiety, enhance coping and communication skills, and intervene in crises. When patients request or prefer to use integrative therapies, the nurse performs assessment and teaching as appropriate. Teamwork and safety. As mentioned earlier, most patients who demonstrate anxiety disorders and obsessive compulsive disorders can be treated successfully as outpatients. Hospital admission is necessary only if severe anxiety or compulsive symptoms interfere with the individual's health or if the individual is suicidal. When hospitalization is necessary, the healthcare team can be especially effective by collaborating to develop a multidisciplinary treatment plan to address goals, interventions, and outcomes that includes the patient's input. Evaluating and refining the plan of care at regular intervals. Documenting the plan and other essential communication electronically through an interactive and secure system. Identifying specific members of the treatment team to be responsible for carrying out specific actions of the plan. Maximizing safety through the provision of calm and consistent care. Stressing the value of unconditional positive regard. Maintaining a safe environment with an atmosphere of low-level stimulation. Providing ongoing education and training for the team to recognize escalating or problematic behaviors. Promotion of self-care activities. Respecting the patient's preferences for how involved they are in self-care, while recognizing that they may require more. Less guidance depending on their level of ability is a fine balance. Including the patient in care decisions is essential whenever possible. Patients with anxiety and obsessive compulsive disorders are usually able to meet their own basic physical needs. Self-care activities that are most likely to be affected are discussed in the following sections. Table 15.10. Interventions for severe to panic levels of anxiety. Priority diagnosis. Anxiety severe. Panic related to perception of a severe threat is evidenced by verbal or physical acting out, extreme immobility, sense of impending doom, and inability to problem solve. Intervention.
Rationale. Maintain a calm manner. Anxiety is communicated interpersonally. The quiet calm of the nurse can serve to calm the patient. The presence of anxiety can escalate anxiety in the patient. Always remain with the person experiencing an acute severe to panic level of anxiety. Alone with immense anxiety, a person feels abandoned. A caring face may be the patient's only contact with reality when confusion becomes overwhelming. Minimize environmental stimuli. Move to a quieter setting and stay with the patient. Helps minimize further escalation of patient's anxiety. Use clear and simple statements of repetition. A person experiencing a severe to panic level of anxiety has difficulty concentrating and processing information. Use a low-pitched voice. Speak slowly. A high-pitched voice can convey anxiety. Low pitch can decrease anxiety. Reinforce reality if distortions occur, e.g., seeing objects that are not there or hearing voices when no one is present. Anxiety can be reduced by focusing on and validating what is going on in the environment. Listen for themes in communication. In severe to panic levels of anxiety, verbal communication themes may be the only indication of the patient's thoughts or feelings. Attend to physical and safety needs when necessary, e.g., need for warmth, fluids, elimination, pain relief, family contact. High levels of anxiety may obscure the patient's awareness of physical needs. Because safety is an overall goal, physical limits may need to be set. Speak in a firm, authoritative voice. You may not let anyone hear. If you can't control yourself, we will help you. A person who is out of control is often terrorized. Staff must offer the patient and others protection from destructive and self-destructive impulses. Provide opportunities for exercise, e.g., walk with nurse, punching bag, ping pong game. Physical activity helps channel and dissipate tension and may temporarily lower anxiety. When a person is constantly moving or pacing, offer high-calorie fluids. Dehydration and exhaustion must be prevented. Assess need for medication or seclusion after other interventions have been tried and have been unsuccessful. Exhaustion and physical harm to self and others must be prevented. Box 15.1. Select NIC interventions for anxiety disorders. Coping enhancement. Definition: facilitation of cognitive and behavioral efforts to manage perceived stressors, changes, or threats that interfere with meeting life demands and roles. Activities. Provide an atmosphere of acceptance. Encourage verbalization of feelings, perceptions, and fears. Acknowledge the patient's spiritual cultural background. Discourage decision-making when the patient is under severe stress. Hope inspiration. Definition: enhancing the belief in one's capacity to initiate and sustain actions. Activities. Assist the patient to identify areas of hope in life. Demonstrate hope by recognizing the patient's intrinsic worth and viewing the patient's illness as only one facet of the individual. Avoid masking the truth. Help the patient expand spiritual self. Self-esteem enhancement. Definition: assisting a patient to increase his or her personal judgment of self-worth. Activities. Make positive statements about the patient. Monitor frequency of self-negating verbalizations. Explore previous achievements. Explore reasons for self-criticism or guilt. Relaxation therapy. Definition: use of techniques to encourage and elicit relaxation for the purpose of decreasing undesirable signs and symptoms such as pain, muscle tension, or anxiety. Activities. Demonstrate and practice the relaxation technique with the patient. Provide written information about preparing and engaging in relaxation techniques. Anticipate the need for the use of relaxation. Evaluate and document the response to relaxation therapy. From Gileka, GM, Butcher, HK, Doctorman, JM, and Wagner, C. 2013. Nursing Interventions Classification, NIC 6th ed. St. Louis, Mo, Mosby. Nutrition and fluid intake. Patients with high levels of anxiety are not focused on eating and drinking. Some phobic patients may be so afraid of germs that they cannot eat. In home settings, individuals who hoard may have created an environment that is so dysfunctional that normal intake may be impossible. Likewise, people who engage in ritualistic behaviors may be too involved with their rituals to take time to eat and drink. In general, nutritious diets with snacks should be provided. Adequate intake should be firmly encouraged, but power struggles should be avoided. Weighing patients frequently, e.g., 3 times a week, is useful in assessing nutrition. Table 15.11. FDA-approved drugs for anxiety disorders. Anxiety disorder. Selective serotonin reuptake inhibitors. Serotonin norepinephrine reuptake inhibitors. Benzodiazepines. Other. Generalized anxiety disorder. Escitalopram Lexapro. Paroxetine Paxil. Venlafaxine Effexor. Duloxetine Cymbalta. Alprazolam Xanax. Chlordiazepoxide Librium. Clorazepate Transient. Diazepam Valium. Lorazepam Ativan. Oxazepam Serax. Buspirone Buspar. Panic disorder. Fluoxetine Prozac. Paroxetine Paxil. Sertraline Zoloft. Venlafaxine Effexor. Alprazolam Xanax. Clonazepam Clonopin. Social anxiety disorder. Paroxetine Paxil. Sertraline Zoloft. Venlafaxine Effexor. Obsessive compulsive disorder. Fluoxetine Prozac. Fluvoxamine Luvox. Paroxetine Paxil. Sertraline Zoloft. Clomipramine Anafranil. Food and Drug Administration, 2016. FDA Label Repository. Retrieved from labels.fda.gov. Burcham, J. and Rosenthal, L. 2016. Lens Pharmacology for Nursing Care, 9th ed. St. Louis, Mo. Elsevier. Personal hygiene and grooming. Some patients with anxiety and obsessive compulsive disorders are indecisive about bathing or about what clothing should be. What clothing should be worn? For the latter, limiting choices to 2 outfits is helpful. In the event of severe indecisiveness, simply presenting the patient with the clothing to be worn may be necessary. You may also need to remain with the patient to give simple directions. Put on your shirt. Now put on your slacks. Matter of fact support is effective in assisting patients to independently perform as much of a task as possible. Encourage patients to express thoughts and feelings about self-care. This communication can provide a basis for future health teaching or for ongoing dialogue about the patient's abilities. Some patients, especially those with obsessive compulsive disorder and phobias, may be excessively neat and engage in time-consuming rituals associated with bathing and dressing. Hygiene, dressing, and grooming may take several hours. Maintenance of skin integrity may become a problem when the rituals involve excessive washing and skin becomes excoriated and infected. Assessment of skin integrity is also a concern for individuals who pull their hair or pick at their skin. Elimination. Patients with severe obsessive compulsive disorder may be so involved with the performance of rituals that they may suppress the urge to void and defecate. Urinary tract infections and constipation may result. Interventions may include creating a regular schedule for taking the patient to the bathroom. Sleep. Patients experiencing anxiety and obsessive compulsive disorders frequently have difficulty sleeping, particularly in falling asleep. Patients with generalized anxiety disorder often experience sleep disturbance from nightmares. Separation anxiety disorder may have such profound fears that sleep seems impossible. Patients may perform rituals to the exclusion of resting and sleeping, and physical exhaustion may occur. Teaching patients how to discover ways to promote sleep, e.g., warm bath, warm milk, and relaxing music, and monitoring sleep through a sleep record are useful interventions. Chapter 19 offers an in-depth discussion of sleep disturbances. Pharmacological interventions. Several classes of medications have been found to be effective in the treatment of anxiety disorders. Table 15.11 identifies medications approved by the U.S. Food and Drug Administration, FDA, for the treatment of anxiety disorders. Refer to Chapter 3 for a more detailed explanation of the actions of psychotropic medications. Antidepressants. SSRIs are considered the first line of defense in most anxiety and obsessive-compulsive related disorders. These SSRIs include paroxetine, Paxil, fluoxetine, Prozac, escitalopram, Lexapro, fluvoxamine, Luvox, and sertraline Zoloft. Some of these antidepressants exert more of an activating effect than others and may actually increase anxiety initially. Fluoxetine and sertraline tend to be the most activating. Paroxetine seems to have a more calming effect than the other SSRIs. Antidepressants have the secondary benefit of treating comorbid depressive disorders. Venlafaxine Effexor is a serotonin norepinephrine reuptake inhibitor (SNRI) that is quite successful in the treatment of several anxiety disorders. Another SNRI, duloxetine Cymbalta, is effective in the treatment of generalized anxiety disorder. Monoamine oxidase inhibitors (MAOIs) are reserved for treatment-resistant conditions because of the risk of life-threatening hypertensive crisis if the patient does not follow dietary restrictions. Patients cannot eat foods containing tyranine and must be given specific dietary instructions. The risk of hypertensive crisis also makes the use of MAOIs contraindicated in patients with comorbid substance use disorders. See Chapter 14 for a full discussion of antidepressants. Anti-anxiety drugs. Anti-anxiety drugs are often used to treat the somatic and psychological symptoms of anxiety disorders. When moderate or severe anxiety is reduced, patients are better able to participate in treatment of their underlying problems. Benzodiazepines are most commonly used because they have a quick onset of action. However, due to the potential for dependence, these medications should be used for short periods, only until other medications or treatments reduce symptoms. An important nursing intervention is to monitor for side effects of the benzodiazepines, including sedation, ataxia, and decreased cognitive function. Paradoxical reactions, reactions that are the exact opposite of intended responses, sometimes occur. Symptoms such as anxiety, agitation, talkativeness, and loss of impulse control may occur when using this classification of medications. Benzodiazepines are not recommended for patients with a substance use disorder. They are not recommended for elderly patients due to risk of delirium, falls, and fractures. The decision to use benzodiazepines during pregnancy should be made by weighing the risk of fetal exposure versus the risk of untreated anxiety disorders. U.S. Department of Health and Human Services, 2012. Benzodiazepine use shortly before delivery can result in a dystonia and muscle weakness in the newborn known as floppy infant syndrome. Withdrawal symptoms in the neonate have been known to occur. Prenatal benzodiazepine exposure increases the risk of oral cleft lip and palate, although the absolute risk increases by only 0.01%. The FDA warns against breastfeeding while taking these drugs since they pass into breast milk. Box 15.2 summarizes important information for patient teaching. Buspar is an alternative anti-anxiety medication that does not cause dependence, but 2 to 4 weeks are required for it to reach full effects. The drug may be used for long-term treatment and should be taken regularly. Side effects include dizziness, nausea, headache, nervousness, lightheadedness, and excitement. Buspar is not recommended for individuals with impaired hepatic or renal function since an increased plasma levels and lengthened half-life may result. There is no direct evidence that this medication poses a danger to the developing infant. The FDA recommends using the drug during pregnancy and breastfeeding only if clearly necessary. Other classes of medications. Other classes of medications sometimes used to treat anxiety disorders include beta blockers, antihistamines, anticonvulsants, and antipsychotics. These agents are often added if the first course of treatment is ineffective. Beta blockers block the receptors that, when stimulated, cause the heart to beat faster. The beta blockers reduce physical manifestations of anxiety by slowing the heart rate and reducing blushing and have been used to treat social anxiety disorder. Anticonvulsants have shown some benefit in the management of generalized anxiety disorder and social anxiety disorder. Gabapentin, Neurontin, and pregabalin Lyrica, for example, are commonly prescribed. Box 15.2. Patient and family teaching, anti-anxiety drugs. 1. Caution the patient not to change dose or frequency of medication without consultation with the prescriber. These medications may make it unsafe to handle mechanical equipment, e.g., cars, saws, and machinery. Avoid alcoholic beverages and other anti-anxiety drugs due to unsafe depressant effects when combined. Avoid drinking beverages containing caffeine because they decrease the desired effects of the drug. Review prescription medications and doses that may cause or increase anxiety, e.g., thyroid hormones, steroids, decongestants. 2. Discuss the risks to the fetus and the risk of untreated anxiety disorders with prescriber should pregnancy occur be considered. 3. Advise the patient to discuss breastfeeding with prescriber because these drugs are excreted in the milk and could have adverse effects on the infant. 4. Teach a patient who is taking monoamine oxidase inhibitors about the details of a tyranny-restricted diet referred to. Chapter 3. 5. Teach the patient that cessation of benzodiazepine use after 3 to 4 months of daily use may cause withdrawal symptoms such as insomnia, irritability, nervousness, dry mouth, tremors, convulsions, and confusion. Medications should be taken with or shortly after meals or snacks to reduce gastrointestinal discomfort. Drug interactions can occur. Antacids may delay absorption. Cimetidine interferes with metabolism of benzodiazepines, causing increased sedation. Central nervous system depressants, such as alcohol and barbiturates, cause increased sedation. Antihistamines are a safe non-addictive alternative to benzodiazepines to lower anxiety levels and again are helpful in treating patients with substance use problems. Antipsychotic medications are useful in treating more severe symptoms of anxiety disorders. There are no FDA-approved drugs for the treatment of the following disorders: separation anxiety, specific phobia, body dysmorphic, hoarding, trichotillomania, and excoriation. Despite the lack of approval, these conditions are often treated with antidepressants, anti-anxiety agents, and the other classes of medications previously described. Pharmacological interventions in children and adolescents. A few drugs are approved specifically for anxiety and obsessive-compulsive disorders in children and adolescents. The FDA approved the SNRI duloxetine Cymbalta in 2014 for children aged 7 to 17 years for generalized anxiety disorder. The FDA has approved 4 medications for use in children with obsessive-compulsive disorder. They are clomipramine, enafranil, fluoxetine, Prozac, fluvoxamine, Luvox, and sertraline, Zoloft. However, medications approved for other age groups are still prescribed off-label. SSRIs are being used for generalized anxiety disorder, panic disorder, and social anxiety disorder with good results. For children with obsessive-compulsive and related disorders, SSRIs are also often used. Image. Psychobiological interventions. Besides medication, there are few biological interventions available to disrupt the course of the anxiety and anxiety-related disorders. Surgery has been used in obsessive-compulsive disorder for those most severely affected. A gamma knife creates irreversible damage known as lesions to certain areas of the brain, resulting in a disconnect of overactive circuits or regions. A relatively new reversible surgical treatment being used for obsessive-compulsive disorder is deep brain stimulation. This technique is considered a valid treatment. Alonso et al., 2015. Electrodes are surgically placed in the subthalamic nucleus of the brain. Then an implanted pulse generator in the chest activates a low-dose current for a specified period of time, several months in some cases. Researchers have reported a decrease of 35% on a measurement of obsessive-compulsive symptoms. Complementary and integrative therapy. Chapter 35 identifies a number of complementary practices or integrative therapies that people use to cope with stress in their lives. Herbal therapy and dietary supplements are commonly used, yet they are not subject to the same rigorous testing as prescription medications. Also, herbs and dietary supplements may not be uniformly prepared or dosed, and there is no guarantee of bioequivalence of the active compound among preparations. Problems that can occur with the use of psychotropic herbs include toxic side effects and herb-drug interactions. Nurses and other healthcare providers should stay current regarding these popular products in order to assist their patients in making informed decisions. One example is kava, which is derived from the roots of Piper mystica, a South American plant. Kava is used as a sedative with anti-anxiety effects. As an alternative to seeking professional care, people with anxiety disorders may try kava in the belief that herbs are safer than medications, but it has a dark side. In 2010, the FDA issued a warning regarding its risk of liver damage. Kava is known to dramatically inhibit the P450 liver enzyme necessary for the metabolism of many medications. This inhibition could result in liver failure, especially when taken along with alcohol or other medications such as central nervous system depressants. Anti-anxiety agents fall into this category. Health teaching. Health teaching is a significant nursing intervention for patients with anxiety disorders. Patients may conceal symptoms for years before seeking treatment and often come to the attention of healthcare providers during a co-occurring problem. People with panic disorder and generalized anxiety disorder seem more motivated than those with other anxiety disorders to get treatment. Most seek help during the first year of symptoms. Wong et al., 2005. Teaching about the specific disorder and available effective treatments is a major step toward improving the quality of life for those with anxiety disorders. Whether in a community or hospital setting, nurses can teach patients about signs and symptoms of anxiety disorders, presumed causes or risk factors, especially substance abuse medications, the use of relaxation techniques, and the benefits of psychotherapy. Relaxation exercises for breathing or muscle groups are extremely useful in initiating a relaxation response. The relaxation response is the opposite of the stress response and results in a reduced heart rate and breathing and relaxed muscles. Refer to Chapter 10 for a description of different approaches to relaxation training. Advanced practice interventions. Psychiatric mental health advanced practice registered nurses use evidence-based cognitive treatment approaches. Behavioral approaches such as modeling, systematic desensitization, flooding, response prevention, and thought stopping are also useful with the anxiety and obsessive compulsive disorders. Cognitive behavioral therapies link both of these approaches. Cognitive therapy. Cognitive therapy is based on the belief that patients make errors in thinking that lead to mistaken negative beliefs about self and others. For example, I have to be perfect or my boyfriend will not love me. Through a process called cognitive restructuring, the therapist helps the patient 1. Identify automatic negative beliefs that cause anxiety, 2. Explore the basis for these thoughts, 3. Reevaluate the situation realistically, and 4. Replace negative self-talk with supportive ideas. Behavioral therapy. There are currently several forms of behavioral therapy, which involve teaching and physical practice of activities to decrease anxious or avoidant behavior. Modeling. The therapist or significant other acts as a role model to demonstrate appropriate behavior in a feared situation, and then the patient imitates it. For example, the role model rides in an elevator with a claustrophobic patient. Systematic desensitization. The patient is gradually introduced to a feared object or experience through a series of steps, from the least frightening to the most frightening graduated exposure. The patient is taught to use a relaxation technique at each step when anxiety becomes overwhelming. For example, a patient with agoraphobia would start with opening the door to the house to go out on the steps in advance to attending a movie in a theater. The therapist may start with imagined situations in the office before moving on to indigo-like exposures. Flooding. Unlike systematic desensitization, this method exposes the patient to a large amount of an undesirable stimulus in an effort to extinguish the anxiety response. The patient learns through prolonged exposure that survival is possible and that anxiety diminishes spontaneously. For example, an obsessive patient who usually touches objects with a paper towel may be forced to touch objects with a bare hand for 1 hour. By the end of that period, the anxiety level is lower. Response prevention. This method is used for compulsive behavior. The therapist does not allow the patient to perform the compulsive ritual, e.g., hand washing, and the patient learns that anxiety does subside even when the ritual is not completed. After trying this in the office, the patient learns to set time limits at home to gradually lengthen the time between rituals until the urge fades away. Thought stopping. Through this technique, a negative thought or obsession is interrupted. The patient may be instructed to say, stop, out loud when the idea comes to mind or to snap a rubber band worn on the wrist. This distraction briefly blocks the automatic undesirable thought and cues the patient to select an alternative or positive idea. After learning the exercise, the patient gives the command silently. Cognitive behavioral therapy. Cognitive behavioral therapy combines cognitive therapy with specific behavioral therapies to reduce the anxiety response. Cognitive behavioral therapy includes cognitive restructuring, psychoeducation, breath restraining and muscle relaxation, teaching of self-monitoring for panic and other symptoms, and in vivo real-life exposure to feared objects or situations. Evaluation. Identified outcomes serve as the basis for evaluation. In general, evaluation of outcomes for patients with anxiety and obsessive compulsive disorder deals with questions such as the following. Is the patient experiencing a reduced level of anxiety? Does the patient recognize symptoms as anxiety related? Does the patient continue to display signs and symptoms such as obsessions, compulsions, phobias, worrying, or other symptoms of anxiety disorders? If still present, are they more or less frequent, more or less intense? Is the patient able to use new behaviors to manage anxiety? Does the patient adequately perform self-care activities? Can the patient maintain satisfying interpersonal relations? Is the patient able to assume usual roles? Quality improvement. Quality improvement attempts to quantitatively measure severity of disorders, develop outcomes and guidelines for care, and monitor patients' progress. In primary care, where most people seek mental health care, evidence-based practice guidelines result in practitioners being more confident in their skills and more likely to treat anxiety. Evidence-based treatment includes using cognitive behavioral therapy, prescribing appropriate medication, and following up with patients. Primary care providers may need expert support to provide this care. Royburn et al., 2010. A variety of instruments are used in quality improvement initiatives for psychiatric disorders. A simple tool for measuring quality improvement for anxiety care is the Clinical Global Impression Severity (CGIS) scale for inpatient, outpatient, or primary care. It asks the clinician to rate the severity of illness on a 7-point continuum from normal to among the most extremely ill. Versteeg and colleagues 2012 developed the following outcomes for use with the tool. At least 80% of patients with anxiety disorders are monitored every 6 weeks with the CGIS scale. After 6 months of treatment, 50% of patients with severe anxiety disorders will score less than 3 on the CGIS. Nurses are at the forefront in gathering information to improve the quality of care in all settings. Understanding anxiety disorders and their treatment is more fully accomplished when we consider the seriousness and importance of continuous quality improvement in providing care. Key points to remember. Anxiety has an unknown or unrecognized source, whereas fear is a reaction to a specific threat. PEPLAU operationally defined 4 levels of anxiety: mild, moderate, severe, and panic. The patient's perceptual field, ability to learn, and other characteristics are different at each level. Defenses against anxiety can be adaptive or maladaptive and viewed in a hierarchy from healthy to intermediate to immature. Anxiety disorders are the most common psychiatric disorders in the United States and frequently co-occur with depression or substance abuse. Another closely related set of disorders is obsessive compulsive disorders in which anxiety results in abnormal selective overattention. Research has identified biological, psychological, and environmental factors in the etiology of anxiety and obsessive compulsive disorders. Patients with anxiety and obsessive compulsive disorders suffer from debilitating anxiety, panic attacks, irrational fears, excessive worrying, uncontrollable rituals, or severe reactions to stress. Embarrassment and shame often prevent people from seeking psychiatric help. Instead, they may go to primary care providers with multiple somatic complaints. Psychiatric treatment is effective for anxiety and obsessive compulsive disorders. Understanding the levels of anxiety will help in planning basic care, including how much direction your patient will need, what precautions should be taken to prevent harm, and how able your patient is to learn. Basic level nursing interventions include counseling, milieu therapy, promotion of self-care activities, psychobiological intervention, and health teaching. Advanced practice nursing interventions include behavioral and cognitive behavioral therapies. Quality improvement initiatives help to measure severity of symptoms and to establish interventions that are evidence-based rather than tradition-based. Critical thinking. 1. Corey is a senior in college and is taking his final examinations for an engineering course. The professor catches him copying from the examination of his willing partner, Katie, and takes his exam away. Corey's heart immediately begins to pound, his pulse and respiration rates increase, and he has to wipe perspiration from his hands and face several times. He feels like he may vomit and has a throbbing in his head. After the examination, he approaches the professor, but has difficulty focusing. When he starts to speak, his voice trembles. Corey says that Katie suggested that cheating is no big deal, that he needed to do it to be competitive, and that it was done all the time. Corey goes on to say to this, silly exam, doesn't mean anything anyway, and that he already passed the important courses. He tells the professor, I thought you were the greatest, and now I see that you're a fool. The professor remains calm and explains that regardless of Corey's thoughts on this matter, he was, in fact, caught cheating, and he will have to take responsibility for his actions. The professor will refer Corey to the disciplinary board. When Corey realizes how serious this incident is, he flips out and yells at the professor and calls him offensive names. Another professor walking past the classroom witnesses this encounter. A. Identify the level of anxiety Corey was experiencing once he was caught cheating, and describe the signs and symptoms that help you determine this level. B. Identify and define 5 defense mechanisms Corey used to lessen his anxiety. Given the circumstances once Corey was caught, how could he have reacted using healthier coping defenses in a manner that would have reflected more self-responsibility? 2. Tiffany, a teenager with obsessive compulsive disorder, washes her hands until they are cracked and bleeding. Your nursing goal is to promote healing of her hands. What interventions will you plan? 3. This is Logan's 3rd emergency department visit in a week. He is experiencing severe anxiety accompanied by many physical symptoms. He clings to you, desperately crying, help me, don't let me die. Diagnostic tests have ruled out a physical disorder. The patient outcome has been identified as patient's anxiety level will be reduced to moderate mild within 1 hour. A. What interventions should you use? Be comprehensive in your approach. B. Logan is given an appointment at the anxiety disorders clinic. How will you explain the importance of keeping the clinic appointment? Are there any factors you would have to consider while providing patient education? 4. Liz is a patient with generalized anxiety disorder. She has a history of substance abuse and is now recovering alcoholic. During a clinic visit, she tells you she plans to ask the psychiatrist to prescribe diazepam Valium to use when she feels anxious. She asks whether you think this is a good idea. How would you respond? What action could you take? Chapter review. Questions. 1. The nurse is providing. Objectives. 1. Describe clinical manifestations of each disorder covered under the general umbrella of trauma-related and dissociated disorders. 2. Describe the symptoms, epidemiology, comorbidity, and risk factors of trauma-related disorders in children. 3. Discuss at least 5 of the neurobiological changes that occur as the result of trauma. 4. Apply the nursing process to the care of children who are experiencing trauma-related disorders. 5. Differentiate between the symptoms of post-traumatic stress, acute stress, and adjustment disorders in adults. 6. Describe the symptoms, epidemiology, comorbidity, and risk factors of trauma-related disorders in adults. 7. Discuss how to deal with common reactions the nurse may experience while working with a patient who has suffered trauma. 8. Apply the nursing process to trauma-related disorders in adults. 9. Develop a teaching plan for a patient with
Post-traumatic stress disorder. 10. Identify dissociative disorders including depersonalization, derealization disorder, dissociative amnesia, and dissociative identity disorder. 11. Create a nursing care plan incorporating evidence-based interventions for symptoms of dissociation, including flashbacks, amnesia, and impaired self-care. 12. Role-play intervening with a patient experiencing a flashback. Key terms and concepts. Acute stress disorder. Adjustment disorder. Alternate personality, alter. Debriefing. Depersonalization. Derealization. Disinhibited social engagement disorder. Dissociation. Dissociative amnesia. Dissociative view. Dissociative identity disorder. Eye movement desensitization and reprocessing. Flashbacks. Neuroplasticity. Post-traumatic stress disorder, PTSD. Reactive attachment disorder. Resilience. Trauma-informed care. Window of tolerance. Icon. Visit the Evolve website for a pretest on the content in this chapter. http://evolve.elsevier.com/dark-arrows. Icon. Traumatic life events are associated with a wide range of psychiatric and other medical disorders. Traumatic events are not always as extraordinary as war and may be as common as interpersonal trauma, sexual abuse, physical abuse, severe neglect, emotional abuse, repeated abandonment, or sudden and traumatic loss in childhood, adolescence, or adulthood. Our understanding of the long-term physiological and psychological effects of trauma has expanded, and effective treatments are available. However, people who need these treatments do not always get the care that they need. Integrating trauma-informed care into all healthcare settings, both behavioral and medical, to reduce the effects of trauma and help to prevent the pervasive and damaging psychological and physical consequences of trauma. Trauma often precedes many psychiatric disorders, according to the American Psychiatric Association. APA, 2013 disorders included under the trauma umbrella include post-traumatic stress disorder, attachment disorders. 1. Reactive attachment disorder. 2. Disinhibited social engagement disorder. Acute stress disorder. Adjustment disorders. Because trauma impacts children in related but different ways, the two populations will be addressed separately. This chapter begins with trauma-related disorders in children and then discusses adult trauma-related disorders. The last part of the chapter addresses dissociative disorders. Dissociative disorders are also related to trauma, specifically early interpersonal trauma. These disorders include depersonalization, derealization disorder, dissociative amnesia, dissociative identity disorder, trauma-related disorders in children, post-traumatic stress disorder. Tragically, children are exposed to many traumatic events without the strength or coping skills to adequately defend themselves. Abuse, interpersonal violence, automobile accidents, natural disasters, war, medical procedures, and illnesses are all traumatizing incidents. Children who have been abused and neglected by their caretakers and other adults are at great risk for developing physical illnesses and psychological problems as a result of their traumatic experiences. According to the National Child Abuse and Neglect Data System 2015, nearly 679,000 children were victims of abuse and neglect in 2013. Neglect is the most prevalent form of child abuse in the United States. Of those children who died from abuse and neglect, about 74% were younger than 3 years old. One or both parents are responsible for nearly 80% of child fatalities, and boys suffer a higher child fatality rate than girls. These statistics only reflect known cases of abuse. There is little doubt that far more children suffer abuse and neglect than are reported to Child Protective Services agencies. Sexual abuse of a child is a particularly reprehensible act. Sexual abuse ranges from forcing a child to observe lewd acts, to fondling, and all the way to sexual intercourse. All instances of sexual abuse are devastating to a child who lacks the mental capacity or emotional maturation to consent to this type of a relationship. Children who are starved for affection may be particularly vulnerable and confused by this attention. Witnessing violence is traumatizing and a well-documented risk factor for many mental health problems, including depression, anxiety, post-traumatic stress disorder, PTSD, aggressive and delinquent behavior, drug use, academic failure, and low self-esteem. Weiland, 2015. Children who have been abused are at risk for abusing others and developing dysfunctional patterns in close interpersonal relationships. Clinical picture. PTSD in preschool children may manifest as a reduction in play, repetitive play that includes aspects of a traumatic event, social withdrawal, and negative emotions such as fear, guilt, anger, horror, sadness, shame, or confusion.
Children may blame themselves for the traumatic event and manifest persistent negative thoughts about themselves, such as, I am a bad person. In addition, there may be a feeling of detachment or estrangement from others and diminished interest or participation in significant activities. Often there is irritability, aggressive or self-destructive behavior, sleep disturbances, problems concentrating, and hypervigilance. The DSM-5 box provides criteria for PTSD in adolescents and adults, followed by criteria for children under the age of 7. DSM-5 criteria for post-traumatic stress disorder. I. Post-traumatic stress disorder for adults, adolescents, and children older than 6 years. A. Exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. 1. Directly experiencing the traumatic events. 2. Witnessing, in person, the events as it occurred to others. 3. Learning that the traumatic events occurred to a close family member or close friend. In cases of actual or threatened death of a family member or friend, the events must have been violent or accidental. 4. Experiencing repeated or extreme exposure to aversive details of the traumatic events, e.g., first responders collecting human remains, police officers repeatedly exposed to details of child abuse. Note: Criterion A4 does not apply to exposure through electronic media, television, movies, or pictures unless this exposure is work-related. B. Presence of one or more of the following intrusion symptoms associated with traumatic events beginning after the traumatic events occurred. 1. Recurrent, involuntary, and intrusive distressing memories of the traumatic events. Note: In children older than 6 years, repetitive play may occur in which themes or aspects of the traumatic events are expressed. 2. Recurrent distressing dreams in which the content and or affect of the dream are related to the traumatic events. 3. Note: In children, there may be frightening dreams without recognizable content. 4. Dissociative reactions, e.g., flashbacks in which the individual feels or acts as if the traumatic events were occurring. Such reactions may occur on a continuum, with the most extreme expression being a complete loss of awareness of present surroundings. Note: In children, trauma-specific reenactment may occur in play. 5. Intense or prolonged psychological distress at exposure to internal or external cues that symbolize or resemble an aspect of the traumatic events. 6. Marked physiological reactions to internal or external cues that symbolize or resemble an aspect of the traumatic events. C. Persistent avoidance of stimuli associated with the traumatic events, beginning or worsening after the traumatic events occurred, as evidenced by 2 or more of the following. 1. Avoidance of or efforts to avoid distressing memories, thoughts, or feelings about or closely associated with the traumatic events. 2. Avoidance of or efforts to avoid external reminders, people, places, conversations, activities, objects, situations that arouse distressing memories, thoughts, feelings about or closely associated with the traumatic events. D. Negative alterations in cognitions and mood associated with the traumatic events, beginning or worsening after the traumatic events occurred, as evidenced by 2 or more of the following. 1. Inability to remember an important aspect of the traumatic events, typically due to dissociative amnesia and not to other factors such as head injury, alcohol, or drugs. 2. Persistent and exaggerated negative beliefs or expectations about oneself, others, or the world, e.g., I am bad, no one can be trusted, the world is completely dangerous, my whole nervous system is permanently ruined. 3. Persistent distorted cognitions about the cause of consequences of the traumatic events that lead the individual to blame himself, herself, or others. 4. Persistent negative emotional state, e.g., fear, horror, anger, guilt, or shame. 5. Markedly diminished interest or participation in significant activities. 6. Feelings of detachment or estrangement from others. 7. Persistent inability to experience positive emotions, e.g., inability to experience happiness, satisfaction, or loving feelings. D. Marked alterations in arousal and reactivity associated with the traumatic events, beginning or worsening after the traumatic events occurred, as evidenced by 2 or more of the following. 1. Irritable behavior and angry outbursts with little or no provocation, typically expressed as verbal or physical aggression toward people or objects. 2. Reckless or self-destructive behavior. 3. Hypervigilance. 4. Exaggerated startle response. 5. Problems with concentration. 6. Sleep disturbance, e.g., difficulty falling or staying asleep or restless sleep. F. Duration of the disturbance criteria B, C, D, and E is more than 1 month. G. The disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. H. The disturbance is not attributable to the physiological effects of a substance, e.g., medication, alcohol, or another medical condition. Specify whether. With dissociative symptoms, the individual's symptoms meet the criteria for post-traumatic stress disorder. In addition, in response to the stressor, the individual experiences persistent or recurrent symptoms of either of the following. 1. Depersonalization. Persistent or recurrent experiences of feeling detached from, and as if one were an outside observer of, one's mental processes or body, e.g., feeling as though one were in a dream, feeling a sense of unreality of self or body or of time moving slowly. 2. Derealization. Persistent or recurrent experiences of unreality of surroundings, e.g., the world around the individual is experienced as unreal, dreamlike, distant, or distorted. Note: to use this subtype, the dissociative symptoms must not be attributable to the physiological effects of a substance, e.g., blackouts, behavior during alcohol intoxication, or another medical condition, e.g., complex partial seizures. Specify it. With delayed expression, if the full diagnostic criteria are not met until at least 6 months after the event, although the onset and expression of some symptoms may be immediate. 2. Post-traumatic stress disorder for children 6 years and younger. A. In children 6 years and younger, exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. 1. Directly experiencing the traumatic events. 2. Witnessing, in person, the events as it occurred to others, especially primary caregivers. Note, witnessing does not include events witnessed only in electronic media, television, movies, or pictures. 3. Learning that the traumatic events occurred to a parent or caregiving figure. B. Presence of one or more of the following intrusion symptoms associated with the traumatic events beginning after the traumatic events occurred. 4. Recurrent, involuntary, and intrusive distressing memories of the traumatic events. Note, spontaneous and intrusive memories may not necessarily appear distressing and may be expressed as play reenactment. 5. Recurrent distressing dreams in which the content and or affect of the dream are related to the traumatic events. Note, it may not be possible to ascertain that the frightening content is related to the traumatic event. 6. Dissociative reactions, e.g., flashbacks in which the child feels or acts as if the traumatic events were occurring. Such reactions may occur on a continuum, with the most extreme expression being a complete loss of awareness of present surroundings. Such trauma-specific reenactment may occur in play. 7. Intense or prolonged psychological distress at exposure to internal or external cues that symbolize or resemble an aspect of the traumatic events. 8. Marked physiological reactions to reminders of the traumatic events. C. One or more of the following symptoms, representing either persistent avoidance of stimuli associated with the traumatic events or negative alterations in cognitions and mood associated with the traumatic events, must be present beginning after the events or worsening after the events. Persistent avoidance of stimuli. 1. Avoidance of or efforts to avoid activities, places, or physical reminders that arouse recollections of the traumatic events. 2. Avoidance of or efforts to avoid people, conversations, or interpersonal situations that arouse recollections of the traumatic events. Negative alterations in cognitions. 1. Substantially increased frequency of negative emotional states, e.g., fear, guilt, sadness, shame, confusion. 2. Markedly diminished interest or participation in significant activities, including constriction of play. 3. Socially withdrawn behavior. 4. Persistent reduction in expression of positive emotions. D. Alterations in arousal and reactivity associated with the traumatic events, beginning or worsening after the traumatic events occurred, as evidenced by 2 or more of the following. 1. Irritable behavior and angry outbursts with little or no provocation, typically expressed as verbal or physical aggression toward people or objects, including extreme temper tantrums. 2. Hypervigilance. 3. Exaggerated startle response. 4. Problems with concentration. 5. Sleep disturbance, e.g., difficulty falling or staying asleep or restless sleep. D. The duration of the disturbance is more than 1 month. F. The disturbance cases clinically significant distress or impairment in relationships with parents, siblings, peers, or other caregivers or with school behavior. G. The disturbance is not attributable to the physiological effects of a substance, e.g., medication or alcohol or another medical condition. Specify whether. With dissociative symptoms, the individual symptoms meet the criteria for post-traumatic stress disorder and the individual experiences persistent or recurrent symptoms of either of the following. 1. Depersonalization. Persistent or recurrent experiences of feeling detached from, and as if one were an outside observer of, one's mental processes or body, e.g., feeling as though one were in a dream, feeling a sense of unreality of self or body or of time moving slowly. 2. Derealization. Persistent or recurrent experiences of unreality of surroundings, e.g., the world around the individual is experienced as unreal, dreamlike, distant, or distorted. Note, to use this subtype, the dissociative symptoms must not be attributable to the physiological effects of a substance, e.g., blackouts or another medical condition, e.g., complex partial seizures. Specify if. With delayed expression, if the full diagnostic criteria are not met until at least 6 months after the event, although the onset and expression of some symptoms may be immediate. American Psychiatric Association, 2013, Diagnostic and Statistical Manual of Mental Disorders, Fifth ed., Washington, D.C., author. Epidemiology. Prevalence rates for PTSD in children under 13 years of age are not available. Research on adolescents indicates a rate of 5%. U.S. Department of Veterans Affairs, 2015, the prevalence for girls is higher than for boys, 8% and 2.3%, respectively. Virtually 100% of children who witness their parents' murder or sexual assault will develop PTSD. Other alarming statistical relationships with PTSD are for children who are sexually abused, 90% exposed to a shooting at school, 77%, and who see community violence, 39%. Comorbidity. Comorbidities increase the child's vulnerability to developing or exacerbating, making worse PTSD symptoms. Children and adolescents who have suffered toxic stress and trauma often meet the criteria for more than one diagnostic category. Even if a child does not have sufficient symptoms for a diagnosis of PTSD, he or she can still suffer from overwhelming nightmares or difficulties with trust, phobias, somatic problems, impulse control, and identity issues, learning and attention problems. Behavioral problems, sleep disorders, depression, suicide attempts, dissociation, and substance abuse problems are all significant comorbidities. Weiland, 2015. These comorbidities cause children to be subjected to an endless cycle of medications, punishments, and inadequate responses that will victimize and stigmatize the child. Risk factors. Biological factors. Genetic. Genetic variability might play a role in how individuals react to stress. Environmental factors also influence the expression of genotype. Research on animals and humans has found that prenatal exposure to maternal stress can influence later responses to stress and behavioral outcomes in the offspring. Funk et al., 2012. Also, early adversity has been found to alter the DNA in the brain through a process called methylation. Vick et al., 2012. Methyl groups are attached to genes that govern the production of stress hormone receptors in the brain. This in turn prevents the brain from regulating its response to stress. Parental nurturing may mediate this response. In the absence of nurturing, children have difficulties with attention and following directions. They are more likely to engage in high-risk behavior as teenagers and show increased aggression, impulsivity, weakened cognition, and an inability to discriminate between real and imagined threats as adults.
Neurobiological. The most rapid phase of brain development occurs during the first 5 years of life, which makes a child particularly vulnerable to adverse events. The right hemisphere develops first. It is involved in processing social emotional information, promoting attachment functions, regulating body functions, and supporting the individual in coping with stress. Because the right brain develops first and is involved with developing templates for relationships and regulation of emotion and bodily function, early attachments are particularly important for healthy development. It is in the context of attachments that regulatory functions develop in the child. Through day-to-day interactions with a caring person, the child develops adaptive coping strategies that support healthy physical and emotional regulation. Neural connections between the limbic system and prefrontal cortex are established between 10 and 18 months of age, and these neural pathways play a crucial role in modulating arousal and emotional regulation. Normally, we take in information from the environment through our senses, match it against previous experiences, and process it adaptively. Experiences are integrated into memory in a way that allows for connection with other memories. In a normal stress response, the hyperarousal in the sympathetic system is balanced by the parasympathetic system. Neuronal circuits connect the amygdala, our emotional brain, to the prefrontal lobe, our logical brain. The prefrontal lobe serves as the translator of the emotions so that amygdala activation can be modulated. The prefrontal area also keeps track of where information has been stored in long-term memory. It is responsible for retrieving memories and then integrating them with sensory input for decision-making. Trauma causes a disruption of the integration of these neural networks. The more intense the arousal, the less likely it is that the experience will be processed. Bergman, 2012. The more helpless and less in control of a situation the person feels, the more vulnerable to pathophysiological changes a person is. In response to trauma, the parasympathetic response triggers a hypoaroused state with dysregulation of the hypothalamic pituitary adrenal axis resulting in dissociation. Dissociation is a disconnection of thoughts, emotions, sensations, and behaviors connected with a memory. This dissociation is different from the normal experience of spacing out and losing time during a movie or when driving. Severe dissociation occurs for those who have suffered significant trauma. Boone, et al., 2012. When dissociation fails, intrusive symptoms such as flashbacks occur. Polyvagal theory posits that the autonomic nervous system is not limited to a fight or flight response to a threat and actually consists of 3 different responses. Porges, 2011. The sympathetic and parasympathetic systems are controlled by the 10th cranial nerve or vagus nerve. The vagus nerve sends and receives information between the body and the brain through 2 major vagus nerves, ventral and dorsal. Responses are as follows. 1. Myelinated ventral vagal responses are activated during social or intellectual engagement when the individual is in a state of pleasant, not overwhelming arousal. This state serves as a gentle break by inhibiting sympathetic responses of the autonomic system. 2. Unmyelinated ventral vagus responses are activated when you perceive a threat. The attending sympathetic arousal symptoms of rapid heart rate and rapid respiration prepare the person for fight or flight responses. After many hours, days, or months, the body cannot sustain this state. 3. The third response is the dorsal vagal response that occurs to dampen down the sympathetic nervous system. This is a parasympathetic response with the heart rate and respiration slowing down and a decrease in blood pressure. Animals in the wild illustrate the ultimate dorsal vagal shutdown by playing dead when extremely threatened. Subjectively, the person may just want to sleep or escape through mind-numbing activities and stay in this hypoarousal or depression. This hypoarousal may alternate with hyperarousal and anxiety. This theory provides an explanation of why many people with PTSD also suffer from depression. Psychological factors. Attachment theory. A psychological theory with implications for trauma-related disorders is attachment theory based on the work of Bowlby, 1988. This theory describes the importance and dynamics of the early relationship between the infant and the caretaker. Attachment patterns or schemas are formed early in life through interaction and experiences with caregivers, and this relationship is embedded in memories. Research has demonstrated that these patterns of attachment persist into adulthood. Environmental factors. Neuroplasticity of the brain describes how experiences reorganize neural pathways. This reorganization is particularly intense in children. It is this neuroplasticity along with a dependency on others that can increase vulnerability to adverse childhood experiences (ACEs). External factors in the environment can either support or put stress on children and adolescents and shape development. Young people are vulnerable in an environment in which systems e.g., schools, court systems, and adults e.g., parents, counselors, have power and control. Parents model behavior and provide the child with a view of the world. If parents are abusive, rejecting, or overly controlling, the child may suffer negative effects during the period of development when the trauma occurs. Most children, however, who suffer traumatic and stressful events, do develop normally. Poverty, parental substance abuse, and exposure to violence have received increasing attention and place minority children at greater risk for trauma and stress. Differences in cultural expectations, presence of stresses, and lack of support by the dominant culture may have profound effects and increase the risk of mental, emotional, and academic problems. Family stability may provide cushioning effects in the face of poverty and adversity. Children brought up in a chaotic or non-nurturing environment suffer neurological consequences that are long-lasting and difficult to remediate. Shonkoff and Garner, 2012. Toxic stress and ACEs often result in lifelong consequences for both psychological and physical health. Trauma in early childhood also plays a role in the intergenerational transmission of disparities in health outcomes. Intriguingly, some children who live with severe or chronic ACEs respond with strength and overcome circumstances that would leave most adults terribly shaken. The term resilience refers to positive adaptation, or the ability to maintain or regain mental health despite adversity. Studies have shown that factors that enhance resilience are the presence of social support and protective factors that include positive emotions and self-efficacy. Lee et al., 2013. Evidence-based practice. Can we help children become resilient? Problem. Adverse childhood experiences (ACEs) are correlated with risk behaviors of smoking, disordered eating, and alcohol and substance abuse. Such behaviors can lead to significant public health problems with chronic obstructive pulmonary disease, obesity, liver disease, and hypertension. We know that some people with ACEs do not appear to suffer negative consequences, but instead bounce back. Purpose of study. The purpose of this pilot study was to explore the benefits of a program called the Empower Resilience Intervention ARI. The ARI was developed to help increase resilience and health behaviors with young adults who have high ACE scores. Methods. All 28 participants had an ACE score of 4, which is significant for ACEs. A 4-week psychoeducation ARI program was provided for 17 undergraduate students. A control group of 11 students did not receive this intervention. Components of ARI included mindful meditation, building personal strength, improving cognitive flexibility, and increasing social support. Both the experimental group and the control group completed a pretest and post-test that compared symptoms, health behaviors, resilience, and asked for personal impressions of themselves. Key findings. There was no significant change in risk behaviors or resilience score by cohort. Young adults in the intervention group reported building strengths, reframing resilience, and creating support connections. Implications for nursing practice. An increase in health behavior should be possible with a strength-based intervention such as this. The sample may have been too small. Evaluating this intervention with a larger sample is important in determining its effects. This short-term intervention holds promise as an opportunity to build on strengths to positively impact the future. Chandler, G.D., Roberts, S.J., and Giotto, L. 2015. Resilience Intervention for Young Adults with Adverse Childhood Experiences. Journal of the American Psychiatric Nurses Association, 21, 6-406-416. Application of the nursing process. Assessment. A child or adolescent with a trauma or stressor-related disorder is one whose development may be delayed if adequate assessment, diagnosis, and treatment are not available. It is important for nurses working in school, community settings, and juvenile detention to assess for PTSD and the safety of the environment for young people who have been traumatized or experienced abuse and a history of violence. The type of data collected to assess the child depends on the setting, the severity of the presenting problem, and the availability of resources. However, assessment is an ongoing process throughout treatment. Methods of collecting data include interviewing, screening, testing neurological, psychological, intelligence observing, and interacting with the child or adolescent. Ideally, histories are taken from multiple sources including parents, other caregivers, the child or adolescent, and other adults such as teachers. A genogram, which is a drawing of a family tree with descriptions of individuals and relationships, can provide a clear illustration of the family referred to. Chapter 35. Assessment of the mental status of children is similar to that of adults. It identifies problems with thinking, feeling, and behaving. Broad categories to assess include safety, general appearance, socialization, activity level, speech, coordination and motor function, effect, manner of relating, intellectual function, thought processes and content, and characteristics of play. The observation interaction part of a mental health assessment begins with a semi-structured interview in which the nurse asks the young person to describe the home environment, parents, and siblings. Information about the school environment, teachers, and peers is also collected. Play activities, such as games, drawings, and puppets, are used for younger children who cannot respond to a direct approach. The initial interview is key to observing interactions among the child, caregiver, and siblings if available, and to building trust and rapport. Essential assessment data include post-traumatic symptoms such as nightmares, night terrors, hallucinations, intrusive traumatic thoughts and memories, re-experiencing or flashbacks of trauma, traumatic reenactments in play, self-injurious behaviors. Traumatized children may have dramatic mood swings and exhibit uncontrollable rage and negative symptoms such as numbing and avoidance. Somatic symptoms may manifest as headaches, stomach or pain. Memory problems include amnesia, forgetfulness, difficulty concentrating, or trance states. Specific assessment tools include the child-associated checklist. Putnam et al. 1993 Trauma Symptoms Checklist for Children. Greer, 1996, and the Child Sexual Behavior Inventory. Friedrich et al. 2001. Developmental Assessment. The developmental assessment provides information about the child's or adolescent's maturational level. Is he behaving and functioning at his chronological age, or are there areas where he lags behind the norms and peers? The Denver 2 Developmental Screening Test for infants and children up to 6 years of age is a popular assessment tool. Frankenberg et al. 1992. For adolescents, tools may be tailored to specific areas of assessment such as neuropsychological, physical, hormonal, and biochemical. Computer-based screening tools for children and adolescents are used in primary care settings to gather sensitive information. Abnormal findings in the developmental and mental status assessments may be temporary. Parents are understandably relieved to learn that behaviors are stress-related. However, intervening early to replace maladaptive coping behaviors with adaptive coping is important to reduce the risk of developing psychiatric disorders. Diagnosis. After a comprehensive trauma assessment, 2 priority nursing diagnoses are applicable. Herdman and Kamatsuru, 2014. The first is risk for impaired attachment, which is defined as being vulnerable to disruption of the interactive process between parent, significant other, and child that fosters the development of a protective and nurturing reciprocal relationship, page 289. Risk factors include anxiety associated with the parent role, ill infant child who is unable to effectively initiate parental contact due to altered behavior or organization, inability of parents to meet personal needs, parental conflict due to altered behavior, substance use, separation. Another nursing diagnosis is risk of delayed development. This is being vulnerable to delay of 25% or more in one or more of the areas of social or self-regulatory behavior, or in cognitive, language, gross or fine motor skills, page 452. Risk factors include substance use, failure to thrive, unstable home, unwanted pregnancy, poverty, outcomes identification. A child with a trauma-related disorder is at risk for developmental and regulatory disorders. A number of outcomes have been identified related to the nursing diagnoses listed previously. Moorhead et al. 2013. An overall attachment outcome would be for the parent and infant child to demonstrate an enduring affectionate bond. With regard to development, general outcomes would pertain to meeting age-appropriate milestones. Implementation. The overall treatment plan for trauma includes psychobiological, psychological, and family goals within a staged treatment protocol. The model of treatment for trauma includes the following stages. Stage 1. Providing safety and stabilization by creating a safe, predictable environment, stopping self-destructive behaviors, providing education about trauma and its effects. Stage 2. Reducing arousal and regulating emotion through symptom reduction and memory work, finding comfort from others, integrating suppressed emotions and accepting ambivalence, overcoming avoidance, improving attention and decreasing dissociation, working with memories and transforming memories. Stage 3. Developmental skills catch up through enhancing problem-solving skills, nurturing self-awareness, social skills training, and developing a value system. Interventions in this phase should focus on teaching coping skills to deal with trauma, supporting efforts to achieve socially appropriate goals, and facilitating use of healthy social support systems. Treatment strategies for the traumatized child are designed to modulate arousal so that the child is helped to stay within a window of tolerance. The window of tolerance is a term that means a balance between sympathetic and parasympathetic arousal. Porges, 2011. See the earlier neurobiological discussion and Fig. 16.1. Traumatized children have difficulty shifting their emotional and physiological states to adapt to different environments. They alternate between hyperarousal, anxiety, fear, hyperactivity, aggression, and hypoarousal withdrawal, isolation, numbness. You can help increase the child's ability to self-regulate using the interventions described in this chapter. These interventions will help to widen the window of tolerance. Interventions. The traumatized child has suffered significant fragmentation of relationships with others. An essential healing ingredient is improving relationships and connection to others. The nurse-patient relationship provides a foundation of connection and caring. Box 16.1 identifies interventions appropriate for a child who has suffered a specific trauma. Interventions for the traumatized child are used in a variety of settings such as inpatient, residential, outpatient, day treatment, outreach programs in schools, and home visits. Many of the modalities can encompass activities of daily living, learning activities, multiple forms of play and recreational activities, and interactions with adults and peers. Other therapies include family therapy, group therapy, play therapy, mutual storytelling, therapeutic games, bibliotherapy, therapeutic drawing, and mindfulness exercises. Image. Fig. 16.1 Therapeutic Window of Arousal Porges. Redrawn from Wheeler, K. 2014. Psychotherapy for the Advanced Practice Psychiatric Nurse. A How to Guide for Evidence-Based Practice. New York, NY, Springer. Box 16.1. Trauma interventions for a child with PTSD. Establish trust and safety in the therapeutic relationship. Use developmentally appropriate language to explore feelings. Teach relaxation techniques before trauma exploration to restore a sense of control over thoughts and feelings. Help the child to identify and cope with feelings through the use of art and play to promote expression. Involve the parents or appropriate caretakers in once unless they are the cause of the trauma. Educate the child and parents about the grief process in response to the trauma. Assist parents in resolving their own emotional distress about the trauma. Coordinate with social work for protections as indicated. Bilekek, GM, Butcher, HK, Doctorman, JM, and Wagner, C. 2013. Nursing Interventions Classification, NIC 6 Ed, St. Louis, Mo, Mosby. If possible, the family is critical in helping a child recover from trauma. Family counseling and education are key components of treatment. Teaching the family how to set limits without being punitive helps the child to feel in control. Often traumatized children need help in dealing with flashbacks, amnesia, or hallucinations. You may, for example, work with a child who developed an imaginary friend as a coping mechanism. She may even think that the friend is really a part of her and not a separate person. In such a case, you can offer reassurance and education. Sometimes when really bad things happen, our brain helps us by forgetting and creating special parts of ourselves that we may think of as friends. Traumatized children need to learn strategies to regulate emotion and arousal levels. Teaching deep breathing techniques and mindfulness techniques helps decrease arousal levels and restore natural rhythms. Soothing strategies that redirect behavior might also include warm baths, singing, distraction, listening to music, and guided imagery. These strategies help the child to manage feelings. Talking about feelings and helping the child to identify emotions are essential. Advanced practice interventions. International guidelines recommend the use of two therapies with this population: cognitive behavioral therapy (CBT) and eye movement desensitization and reprocessing (EMDR) therapy. These are first-line treatments for traumatized children. World Health Organization, 2013. CBT uses a range of strategies such as psychoeducation, behavior modification, cognitive therapy, exposure therapy, and stress management to help the child manage behavior and change maladaptive beliefs and thoughts. EMDR therapy is an innovative evidence-based therapy used to treat children and adults by professionals with advanced training. Wheeler, 2014. EMDR therapy processes traumatic memories through a specific 8-phase protocol. The advanced practice nurse asks the patient to think about the traumatic event. At the same time, the patient attends to other stimulations such as eye movements, audio tones, or tapping. The combination of thinking and other stimuli bring about neurological and physiological changes that help people process and integrate traumatic memories. Specific protocols have been developed for the treatment of children. Even if the child does not remember what happened, EMDR therapy can be helpful. Psychopharmacology. Currently, there are no FDA-approved medications for children with PTSD. Selective serotonin reuptake inhibitors (SSRIs) may improve social and school functioning and decrease avoidance, numbing, and dissociation. Medications that target specific symptoms or comorbidities such as attention deficit hyperactivity disorder (ADHD) or depression can enhance the child or adolescent's potential for growth and may make a real difference in a family's ability to cope and quality of life. Medicating children works best along with another treatment such as CBT or EMDR. Evaluation. Treatment is effective when 1. The child's safety has been maintained. 2. Anxiety has been reduced and stress is handled adaptively. 3. Emotions and behavior are appropriate for the situation. 4. The child achieves normal developmental milestones for his or her chronological age. 5. The child is able to seek out adults for nurturance and help when needed. Attachment disorders. Attachment at its most basic level ensures survival of the species. Lack of attachment is counter to such a basic drive. Tizard 1977 conducted one of the best known, but tragic studies related to attachment disorders. Children in this study were abandoned by their parents and lived in an institution. They were provided with play areas, books, and basic needs. They were not provided with an adequate number of caregivers, and caregivers were instructed not to form attachments with the children. After 4 years, 8 of the 26 children managed to somehow form an attachment with caregivers, 8 of the children became emotionally unresponsive, and 10 of the children became indiscriminately social and attention-seeking. Children may suffer relationship trauma from a grossly inadequate caregiving environment. Disordered responses to these environments may be one of the two extremes described above: severe emotional inhibition or indiscriminately social behaviors. Children with reactive attachment disorder have a consistent pattern of inhibited and emotionally withdrawn behavior. The child rarely directs attachment behaviors toward any adult caregivers and does not seek comfort from them when distressed. This problem is caused by lack of bonding experiences with a primary caregiver by the age of 8 months. This lack of bonding may be due to severe neglect, repeated changes of primary caregivers, or care in an institutional setting. A seemingly opposite response to inadequate parenting is manifested in disinhibited social engagement disorder. These children come across as being remarkably friendly and confident. They demonstrate no normal fear of strangers and are usually willing to go off with people who are unknown to them. Their words, e.g., I really like you, and physical behavior, e.g., attempts to sit on a stranger's lap, are overly familiar and inconsistent with culturally sanctioned and age-appropriate social boundaries. Children with disinhibited social engagement disorder rarely check back with adult caregivers and seem unfazed by separation from them. By attaching to everyone, they are really not attaching to anyone. Reactive attachment disorder and disinhibited social engagement disorder are rare. The rates of these problems have been estimated at 1% of all children under the age of 5. Attachment disorders are often comorbid with other disorders associated with early deprivation. Reactive attachment disorder exists alongside depressive disorders, social problems, PTSD, and cognitive and language problems. Disinhibited social engagement disorder is often seen with ADHD, PTSD, and cognitive and language delays. For children with symptoms of attachment disorder, the disturbances of attachment interview may be administered. Smythe and Zena, 1999. Once diagnosed, children with reactive attachment disorder respond surprisingly well to structure, consistency, and a loving environment. Some evidence of the problem may continue with age. Disinhibited social engagement disorder is more difficult to address. The indiscriminate behavior and attention-seeking persists into adolescence, but becomes less pronounced with adults and more focused on peers. Attachment therapies involve improving the interaction between caregiver and child and are quite effective. Some other attachment therapies are controversial. The most common is holding therapy, in which a child is forcibly held or even laid upon by therapists or parents. Through a combination of restraint and confrontation, the goal is to produce a certain amount of rage that results in a catharsis or release. At that point, the child may become infantile and then reparented by cradling, rocking, and even bottle feeding. Trauma-related disorders in adults. Post-traumatic stress disorder. As in children, PTSD in adults is characterized by persistent re-experiencing of a highly traumatic event that involves actual or threatened death or serious injury to self or others, to which the individual responded with intense fear, helplessness, or horror. PTSD may occur after any traumatic event that is outside the range of usual experience. Examples are military trauma, natural disasters, human disasters, e.g., airplane crashes, crime-related events, or diagnosis of a life-threatening illness. PTSD may be brought about by indirect exposure to trauma, such as learning that a loved one or friend has experienced violence or accidentally died. First responders who are subjected to repeated or extreme exposure to gruesome scenes or details are also at risk. PTSD symptoms can begin after a month from exposure, but a delay of months or years is not uncommon. See the DSM-5 box with the criteria for PTSD. The flashbacks and hypervigilance of PTSD can be terrifying. When the person recalls a traumatic memory, physiological reactions, e.g., sensation of terror in the stomach, heart palpitations, muscles tensing, occur. The person often does not know where these sensations are coming from and attributes them to present circumstances, and the past becomes the present. Because of the changes in the brain, the individual can fluctuate radically from moments of overstimulation and anxiety to moments of complete shutdown and depression. Just when the person feels at rest, as well as sleep, intrusive flashbacks may occur. Victims who suffer from PTSD begin to feel permanently damaged and often hate themselves for feeling so needy and helpless. Epidemiology. Epidemiological studies confirm that most 55% to 90% people have experienced at least one traumatic event in their lifetimes, with an average of 5 traumatic events reported per person. Centers for Disease Control and Prevention, 2010. An individual's response to the long-term sequelae of a disturbing event are highly variable. Responses depend on a multitude of factors such as the person's age, developmental stage, coping skills, support system, cognitive deficits, pre-existing neurophysiology, and the nature of the trauma. Following a traumatic event, nearly 8% of people will develop PTSD. Kessler et al., 1995, with some populations particularly vulnerable. The lifetime prevalence for PTSD is 3.5% of the adult population in the United States, with more than a third of these cases classified as severe. National Institute of Mental Health, 2015. The average age of onset is 23 years old, with women more than twice as likely as men, 10% versus 4%, to develop PTSD. This may be due to the greater incidence of sexual assault on women and also the higher likelihood for women to have past mental health problems such as anxiety and depression, which may make them more vulnerable to response to a traumatic event. Broadus, 2016. Comorbidity. Comorbidities for adults with PTSD include major depressive disorder, anxiety disorders, sleep disorders, and dissociative disorders. Often substances are used to try to manage the feelings and symptoms. Individuals with PTSD are sad, anhedonic, aggressive, angry, guilty, dissociated, and abuse substances. Difficulty with interpersonal, social, or occupational relationships nearly always accompanies PTSD, and trust is frequently an issue of concern. Presenting symptoms include chronic pain, migraines, and vague somatic complaints. Anxiety or depression, irritability, avoidance, anger or non-adherence, self-risk behavior, threatening or aggressive behavior, dissociative symptoms, or change in functioning are also common. Some individuals who are victims of spousal abuse may be hypervigilant and irritable. Sometimes people with PTSD use substances in an attempt to self-medicate to relieve anxiety. Risk factors. See earlier discussion on biological factors in trauma-related disorders for children. Application of the nursing process. Assessment. Screening tools for PTSD in adults include the Primary Care PTSD Screen. PCPTSD, Prince et al., 2003, and the PTSD Checklist, PCL5. Weathers et al., 2013. A more comprehensive assessment is indicated for those who initially screen positive. The severity of post-traumatic stress scale. Kilpatrick et al., 2013, is provided in Big, 16.2. Additional history about the time of onset, frequency, course, severity, level of distress, and degree of functional impairment is important. Further assessment for suicidal or violent ideation, family and social supports, insomnia, social withdrawal, functional impairment, current life stressors, medication, past medical and psychiatric history, and a mental status exam are indicated. Refer to Chapter 7. The diagnosis of PTSD involves a comprehensive clinical interview that assesses all symptoms collectively. Diagnosis. After a comprehensive assessment, a priority nursing diagnosis is applicable. Erdman and Kamasuru, 2014. Post-trauma syndrome is defined as having a sustained maladaptive response to a traumatic overwhelming event, page 315. Based on this definition, a diagnostic statement would be post-trauma syndrome with a related factor of a distressing event that is considered to be outside the range of usual human experience. Outcomes identification. Outcomes for trauma-related disorders for an adult or two. 1. Manage anxiety as demonstrated by use of relaxation techniques, adequate sleep, and ability to maintain role or work requirements. 2. Increased self-esteem is demonstrated by maintenance of grooming hygiene, maintenance of eye contact, positive statements about self, and acceptance of self-limitations. 3. Improve ability to cope is demonstrated by a decrease in physical symptoms and ability to ask for help and in seeking information about treatment. Implementation. A stage model of treatment is previously described for children as the standard for trauma treatment for adults as well. A primary consideration for caring for the person with PTSD is establishing a therapeutic relationship through non-judgmental acceptance and empathy. In this context, the nurse assists the person in managing his or her arousal level. The latter can be accomplished through providing a safe, predictable environment. Teaching strategies to manage anxiety such as deep breathing, imagery, and mindfulness exercises is a very simple intervention. You can also help the patient to connect with support groups, family, and friends. The person often feels guilty and responsible for the event, and the nurse, as a witness through listening and reflecting back to the person his or her concerns, can gently suggest that the person was not responsible for what happened. By sharing the experience, the patient can begin to heal and integrate what happened into his or her life. Image. Big. 16.2 severity of post-traumatic stress symptom scale. Psychoeducation. Initial education should include reassurance that reactions to trauma are common and that these reactions do not indicate personal failure or weakness. The nurse should inform the patient and significant others of the many ways that trauma can be manifested. Interpersonal problems with family and friends, occupational problems, and/or substance use disorders and problems with alcohol use are common symptoms. Strategies to improve coping, enhance self-care, and facilitate recognition of problems are essential. Patients experiencing such severe stress will benefit from relaxation techniques and in the avoidance of caffeine and alcohol. Psychopharmacology. The best evidence supports the use of selective serotonin reuptake inhibitors (SSRIs) for PTSD symptoms. Currently, the FDA has approved 2 drugs, sertraline Zoloft and paroxetine Paxil. From the perspective of the FDA, all other medications are used off-label. Phenylzine Nardole is a monoamine oxidase inhibitor that has been used with some success in PTSD. A serotonin norepinephrine reuptake inhibitor (SNRI), such as venlafaxine Effexor, may be used to decrease anxiety and depressive symptoms. Tricyclic antidepressants (TCAs) or mirtazapine Remeron may be prescribed if SSRIs or SNRIs are not tolerated or do not work. Clonidine Catapris is a centrally acting alpha-2 receptor agonist used to address hyperarousal and intrusive symptoms. Prazosin Minipress is an alpha receptor antagonist used for nightmares and sleep disturbances. Propranolol Inderal, a beta blocker, is used for hyperarousal and panic. The most difficult to tolerate side effect of these medications is hypotension. The FDA recently agreed to new trials for MDMA, the illegal party drug known as ecstasy, as a relief for PTSD patients. Phillips, 2016. Phase 3 clinical trials of the drug are underway as a final step for approval of ecstasy as a prescription drug. After 3 doses of MDMA, patients reported a 56% decrease in symptom severity on average. Follow-up examinations found that improvements lasted more than a year after therapy. The drug reduces painful memories and helps patients to stop substance use. Case study and nursing care plan. Post-traumatic stress disorder. A distraught wife brings Mr. Blake, 46, to the emergency department after she finds him writing a suicide note and planning to shoot himself in the woods with a handgun. Mr. Blake is subdued, shows minimal affect, and his breath smells of alcohol. He states that he is worthless and that his family would be better off if he were dead. He is hospitalized to protect him from danger to himself. Mr. Blake's wife states that her husband is a contractor who served during the Iraq War. He lost half his squad from a roadside bombing and narrowly escaped with his life. Upon returning home, he told his wife, "I don't deserve to live. I should have died with the others." Over the next 6 months, Mrs. Blake noticed that he was having trouble sleeping, his mood was irritable or withdrawn, and he started to drink daily. He complained of nightmares but wouldn't talk about them. He agreed to go to his primary care nurse practitioner for sleep medication. On the psychiatric unit, Mr. Blake is assigned to Ms. Dawson, a registered nurse. She observes that Mr. Blake is quiet as he is oriented to the unit, but that he looks around vigilantly and is easily startled by sounds. Self-assessment. Ms. Dawson is a registered nurse with an associate degree and 3 years of experience on this unit. Initially, she feels sympathy for Mr. Blake, and he reminds her of her Uncle James who served in Vietnam. She is concerned because his suicide plan was legal and he is not sharing his thoughts or feelings. Ms. Dawson implements suicide precautions while demonstrating an attitude of hope and acceptance to develop trust. Assessment. Mr. Blake was administered the PCL-5, which is a 20-item self-report scale of symptoms of PTSD. He scored significant for PTSD with this measure. The nurse obtained the following subjective and objective data. Subjective data. I don't deserve to live. I should have died with the others. Sleep difficulty, nightmares. Feels estranged from wife and children. Refusal of treatment and safety contract. Plan for suicide. Objective data. Hypervigilant. Alcohol on breath. Irritability. Withdrawn mood. Constricted reduced range of affect. Priority diagnosis. Risk for suicide is evidenced by suicide plan and verbalization of intent. Outcomes identification. Patient will remain safe while in the hospital. Planning. The initial plan is to maintain safety for Mr. Blake while encouraging him to express feelings and recognize that his situation is not hopeless. Implementation. Mr. Blake's plan of care is personalized as follows. Short-term goal. Intervention. Rationale. Evaluation. 1. Patient will speak to staff whenever experiencing self-destructive thoughts. 1A. Administer medications with mouth checks. 1B. Provide ongoing surveillance of patient and environment. 1C. Use direct, non-judgmental approach in discussing suicide. 1A. Addresses risk of hiding medications for future overdose. 1B. Provides one-to-one monitoring for safety. 1C. Shows acceptance of patient situation with respect. Goal met. After 8 hours, patient contracts for safety every shift and starts to discuss feelings of self-harm. 2. Patient will express feelings by the 3rd day of hospitalization. 2A. Interact with patient at regular intervals to convey caring and openness and to provide an opportunity to talk. 2B. Use silence and listening to encourage expression of feelings. 2C. Be open to expressions of loneliness and powerlessness. 2D. Share observations or thoughts about patient's behavior or response. 2A. Encourages development of trust. 2B. Shows positive expectation that patient will respond. 2C. Allows patient to voice these uncomfortable feelings. 2D. Directs attention to here and now treatment situation. Goal met. By 2nd day, patient occasionally answers questions about feelings that admits to anger and grief. Table continued. Short-term goal. Intervention. Rationale. Evaluation. 3. Patient will express desire to live by discharge from unit. 3A. Listen to expressions of grief. 3B. Encourage identification of strengths and abilities. 3C. Explore with patient previous methods of dealing with life problems. 3D. Assist in identifying available support systems. 3D. Refer to spiritual advisor of individual's choice. 3A. Supports patient, communicating that such feelings are natural. 3B. Affirms patient's worth and potential to survive. 3C. Reinforces patient's past coping skills and ability to problem solve now. 3D. May have pushed others away. Support systems can also be community groups. 3E. Allows opportunity to explore spiritual values and self-worth. Goal met. By 3rd day, patient becomes tearful and states that he does not want to hurt his wife and daughter. Evaluation. See individual outcomes and evaluation within the care plan. Advanced practice interventions. Evidence-based treatments for PTSD include trauma-focused psychotherapy that may include components of exposure and/or cognitive restructuring and EMDR therapy. These modalities are often combined with anxiety management, stress reduction that focuses on alleviation of symptoms. Other helpful strategies include brief psychodynamic psychotherapy, imagery, relaxation techniques, hypnosis, and group therapy. Evaluation. Treatment is effective when 1. The patient recognizes symptoms as related to the trauma. 2. The patient is able to use new strategies to manage anxiety. 3. The patient experiences no flashbacks or intrusive thoughts about the traumatic event. 4. The patient is able to sleep adequately without nightmares. 5. The patient can assume usual roles and maintain satisfying interpersonal relationships. See the case study and nursing care plan. Acute stress disorder. Acute stress disorder (ASD) may develop after exposure to a highly traumatic event such as those listed in the section on PTSD. Symptoms develop immediately after the event, but a diagnosis is not made until they have persisted for 3 days. The diagnosis must be made within a month of the trauma. After a period of a month, the stress response will begin to resolve or go on to become PTSD. Vignette. At a party, a male sexually assaults John, a 22-year-old college student. After John is brought to the emergency department by a friend, he describes feeling detached from his body. He can't remember his surroundings during the assault. It feels like it took place in a vacuum. He is agitated, irritable, and tells his friend to leave. John has difficulty concentrating on the examiner's questions. After a week, John still feels as though his mind is detached from his body. He reports having difficulty sleeping, nightmares, headaches, not being able to concentrate, and startling whenever anyone touches him. Diagnosis. As with PTSD, an appropriate nursing diagnosis for a patient with ASD NANDA 2012 is post-trauma syndrome related to victimization is manifested by alterations in concentration, anger, dissociative amnesia, headache, irritability, nightmares. Outcomes identification. Outcomes will focus on attaining mood equilibrium and well-being. For anxiety, a general outcome may be that the patient's anxiety level be maintained at mild to moderate. Implementation. The nurse's role in caring for a patient with ASD begins with establishing a therapeutic relationship with the person. Based on this relationship, the nurse can help keep the person safe and monitor response to treatment. Promoting problem solving, connecting the person to support such as family and friends, and providing education about ASD are also important interventions. Other responsibilities include coordination of care through collaboration with others and providing referrals for continued treatment. There are few studies that evaluate the efficacy of treatments for ASD. Historically, critical incident stress debriefing (CISD) has been used for those who have suffered from acute trauma. Typically, debriefing occurs within 12 to 48 hours after the traumatic event and is often offered as a group intervention. Group members receive information on the facts of the event and psychological consequences of trauma and the possible ways of coping, and they exchange the details of the incident. Research on CISD has not supported its efficacy as an intervention after a traumatic event. In fact, several studies have found a higher incidence of PTSD for those who receive CISD. Bison and Andrew, 2007. Advanced practice interventions. CBT is effective in reducing the subsequent development of PTSD for people with ASD. Other promising new therapies for ASD include specialized protocols for EMDR, the EMDR protocol for recent critical incidents, EMDR Tracy, the recent event protocol, and the recent traumatic episode protocol, RTEP. Luber, 2014. Evaluation. See the evaluation section for PTSD previously discussed in this chapter. Adjustment disorder. What may be considered to be a milder, less specific version of ASD and PTSD is adjustment disorder. Like ASD and PTSD, it is precipitated by a stressful event. However, the event, including retirement, chronic illness, or breakup, may not be as severe and may not be considered a traumatic event. This problem may be diagnosed immediately or within 3 months of exposure. The hallmarks of adjustment disorder are cognitive, emotional, and behavioral symptoms that negatively impact functioning. Responses to the stressful event may include combinations of depression, anxiety, and conduct disturbances. Symptoms of adjustment disorder run the gamut of all forms of distress, including guilt, depression, anxiety, and anger. These feelings may be combined with other manifestations of distress, including physical complaints, social withdrawal, or work or academic inhibition. Quality of life scores are higher with adjustment disorder than for major depression, but lower than for people without any disorder. Fernandez et al., 2012. There is a type of adjustment disorder that addresses the needs of those who have lost a loved one within the past 12 months, a sort of complicated grief. This type of adjustment disorder is manifested by intense yearning, longing for the deceased, and intense sorrow and emotional pain or preoccupation with the deceased or the circumstances of the death. In addition, the person may feel anger, a diminished sense of self, emptiness, and or difficulty in relationships or in planning future activities. This may be in accordance with cultural norms. The reported prevalence of adjustment disorder varies widely depending on the setting studied. For example, in those hospitalized, adjustment disorder was found to occur in 50% of the population. Papa, 2013, whereas in a primary care setting, it is estimated at 3% of the population. Fernandez et al., 2012. Thus, treatment of adjustment disorder is not uniform due to the lack of specificity of the problem, and practitioners do not usually recognize this disorder. Symptoms are generally treated with antidepressants. Dissociative disorders. Dissociative disorders occur after significant adverse experiences, traumas, and individuals respond to stress with a severe interruption of consciousness. Dissociation is an unconscious defense mechanism that protects the individual against overwhelming anxiety through an emotional separation. However, this separation results in disturbances in memory, consciousness, self-identity, and perception. Patients with dissociative disorders have intact reality testing. This means that although the person may have flashbacks or images, these are triggered by current events, relate to the past trauma, and are not delusions or hallucinations. Mild fleeting dissociative experiences are relatively common to all of us. For example, we say we are on autopilot when we drive home from work and cannot recall the last 15 minutes before reaching the house. These common experiences are distinctly different from the processes of pathological dissociation. Dissociation is involuntary and results in failure of the normal control over a person's mental processes and normal integration of conscious awareness. Dimensions of a memory that should be linked are not and are fragmented. For example, a person may be aware of a sound or smell, but these sensations would not be linked to the actual event itself, leaving the person fearful and or confused. In addition, the person may reenact, as well as re-experience, trauma without consciously knowing why. Symptoms of dissociation may be either positive or negative. Positive symptoms refer to unwanted additions to mental activity such as flashbacks.
Welcome back, folks. It's break time, so you guys know the drill. Make sure you guys take a stretch break, drink some water, use your restroom, grab a meal if you haven't already. Hope you guys enjoy breaks. I'll meet you guys back in around 10 minutes. Enjoy breaks, everyone.
Okay. That's fine, thank you. Hey, Ben, you're getting an admission in the next 15 minutes, coming from the outpatient clinic.
Okay, what can you tell me about this client?
Well, Susan Choi is 33 years old. She's been followed for depression over the past 6 months and is being admitted for acute mania. She's on administrative leave from her employment as a certified public accountant. She's single and resides in her parents' home. Her behavior has become very unpredictable, so her mother brought her into the clinic to see Dr. Price.
Is she taking any medications?
She started on fluoxetine 20 milligrams a day, but her provider recently increased the dosage to 20 milligrams twice a day, so her provider doubled the dose. She is being admitted for evaluation and stabilization.
Okay, I'll make sure the room is ready.
Great, thanks, Ben.
Let's go. Ben, this is Susan. Okay, thanks, Andrew. You bet. Hi, Susan. And you are?
Just standing. Mrs. Choi, Susan's mother. You can call me Mrs. Choi.
Okay, Susan. I'm going to spend some time getting to know you. Let's see. Your date of birth is...
I'm 33 years old. Born February 22nd.
Okay, so before we go to the conference room, we're going to stop in the treatment room so I can get your vitals. I'll show you to your room later. Your vital signs look fine, Susan. From the information I have here, you've been treated for depression and done well for quite some time. But now you are having problems focusing, such as eating, sleeping.
I'm doing great. I couldn't be better. I get all the sleep I need. Fluoxetine is a miracle drug.
Hey folks, hope you guys are enjoying your break.
Are a
No
miracle.
feel for another session. Stay back in for another one. And
I see your provider is Dr. Price.
Dr. Price is a jewel.
7,
The Price is right. He is bright.
4,
He says I'm all right. He knows I'm the morning light.
1.
I don't need to be here. You need to save the bed for someone who's really sick.
Mrs. Choi, do you recall any history of depression or mania in your family?
No, nothing like this. Back in South Korea, my father went through a dark depression, but I think it was related to the financial loss of my business. We lost all our savings. And that was a long time ago. Where are you from?
understand this question if genetics is a factor in the development of bipolar disorders. That's why I think it's important to provide this information.
But everything's important. I'm important. Don't you feel important too? And can I tell you about all the important things I have to do?
I know thoughts are racing through your mind, Susan. We'd like to take some steps to help you slow down, eat better, and sleep through the night. Let's all head to your room. Okay, Susan, here's your room.
Could be here too, man. Oh, I'd like to get to a room. This is a wild thing to make my bells ring. Oh, Susan, please. I tried then, but I can't stop touching you. I'll try again.
You need to do more than try. There's a no touching policy on this unit, and you need to stop now. Other nurses are going to remind you as well. Now, Mother brought you some clothes. They're here in the suitcase. Why don't you change into something more comfortable? Once you change your clothes, I'll return to give you some medication that Dr. Price prescribed for you.
The price is right. Hi, Ben. Is that medication for Susan Choi? What are you giving her?
This is olanzapine, 10 milligrams IM. There's a prescription from Dr. Price to administer at stat, and Susan really needs this medication.
Olanzapine is an antipsychotic. Doesn't Susan have a bipolar disorder? Won't she also take lithium?
Yes, the plans are to have Susan start on lithium therapy, possibly tomorrow. Lithium takes 7 to 14 days to have a calming effect on clients. So, a client with acute mania can receive an antipsychotic medication like olanzapine to prevent exhaustion, coronary vascular collapse, and death.
Wow, I forgot how serious acute mania can be. Thanks for reminding me about the expected outcomes.
You're welcome. Could you check this medication calculation? I had to reconstitute it and would like to have you double check it for accuracy.
Sure, let me see.
Ben, I didn't calculate the same amount as you did. Try to refigure your calculation.
Thanks for catching that. I have to be sure to give the correct dosage to Susie.
Sure, it always helps to have someone double check your calculation if you're unsure of yourself.
Okay, Susan. I'd like you to meet Eva, one of the other nurses on our unit. I have the medication that Dr. Price prescribed for you. Mrs. Jordan. This is going to help you.
What's that? I'm not taking that. I don't need it. Take my pills. Get it out of here right now!
Okay, Susan. I'll document in your record that you refuse this medication. If you change your mind, don't hesitate to let me know.
Maybe we should talk to Susan about the reason for the student's medication. If she continues to refuse, you should call Dr. Price with that instruction.
Susan, let's talk about why Dr. Price prescribed this medication.
Talk is hot. Talk to me if you want.
But I'm not going to take a shot.
Receiving the medication by injection will help you feel better quickly. Afterward, you can continue to take your oral medication.
So you think this is going to help?
I think you will feel a lot better if you allow us to give it to you now.
Okay, I guess. If Dr. Price thinks it's going to help.
Does anyone have anything to add to that?
Hello, everybody. What's going on in here?
Susan, this is group time.
Let's liven this party up and have a little fun.
Everyone, this is Susan. She's new on our unit today.
How do you do? Nice to meet you.
Ben, I've heard some concerns from our clients about yesterday's group session.
Really? What was the problem?
When you invited Susan to participate in the group, several of the clients reported they were very uncomfortable with her disruptive behavior during the session, and it changed the interactive dynamics of the group. Do you think that was the best decision for everyone involved in the group session?
Looking back, it was hard for everyone to stay focused when Susan joined the group. Perhaps Susan wasn't ready to join everyone.
Oh, hey, Ben. I was just wondering why they keep so much blood in this.
Oh, Dr. Price.
I'm not sick and I want my temperature. Have you got an infection? You're not thinking of AIDS. Did you tell them I have AIDS?
Susan, of course I didn't tell them anything. Dr. Price assesses your ability to tolerate lithium by reviewing your laboratory work. That's why you had to go wrong. Jan, I'm reviewing Susan Choi's laboratory work and called the results into Dr. Price. He says there are specific lab tests prior to starting lithium therapy. I thought the labs I needed to monitor are these, but he informed me that the essential labs to monitor are actually these. He was glad to hear all of Susan's values are within the expected reference range. Based on those findings, he prescribed lithium therapy. So I administered her first dose of 300 milligrams orally.
Well, that's good news. I'm glad you understand how important it is to monitor the correct laboratory reports before initiating lithium therapy. Now that Susan has had her first dose of lithium, you need to review the relevant lab tests while she's on the lithium and do client teaching so that she knows how to manage her medication and prevent complications.
Jan, I reviewed Susan Choi's laboratory work and called the results into Dr. Price. Her renal panel and thyroid studies are within the expected reference range, and she's not pregnant. Based on those findings, Dr. Price prescribed lithium therapy, so I administered her first dose of 300 milligrams orally.
Well, that's good news. I'm glad you understand how important it is to monitor the correct laboratory results before initiating lithium therapy. Because lithium can cause harm to a developing fetus, we need to be sure that Susan is not pregnant, so it's good that you know that. Now that Susan has had her first dose of lithium, you need to review the relevant lab tests while she's on the lithium and do client teaching so that Susan knows how to manage her medication and prevent complications.
Susan and Mrs. Choi, I want to spend some time explaining how important lithium is to helping manage Susan's mood swings. There are several important pieces of information I'd like to discuss.
That would be great. We always like to be informed. What do we need to know?
Susan, Mrs. Choi, Susan should consume 2 to 3 liters of fluid per day, maintain a normal salt intake, and always take the medication with meals to prevent upset stomach. There's no need to worry about changing positions slowly or avoiding foods such as dried beef, aged cheeses, smoked meat or fish, sausages, and figs.
Why is it important to keep a normal salt intake? In my husband's practice, he's usually instructed his clients to limit the salt intake.
That's a good question, Mrs. Choi. You see, lithium is an ion that's chemically very similar to sodium or salt. If the body doesn't have enough salt, it absorbs and retains more lithium. That can result in lithium toxicity.
Okay, thank you. That does make sense now, and will help me remember the importance of sodium in Susan's diet.
Several staff members and I are going to meet now to create a plan of care for Susan's recovery.
to develop a consistent and safe approach for Susan to channel her energy and provide the care required to help her recovery.
I agree, Jan. I'm going to meet this afternoon with Susan and her mother to review what we have planned, including dietary needs.
Good.
Okay, Susan, here is your evening meal. Would you like to continue and sit here?
Looks great. I think I'm gonna take it with me though. We got places to go. Ooh, this is the sea.
Susan, it looks like there are plenty of high-energy foods to keep you going. Are you sure you don't want to sit down while you eat?
Things to keep me going. On.
Hey, Ben, we need to be preparing Susan Choi for her discharge. Where are you at on your discharge teaching?
Well, we need to discuss with Susan and her mother signs and symptoms of lithium toxicity. I plan to do that this morning.
Oh, that's good to hear. It's important to reinforce this information several times before her day of discharge. Susan and her mother need to have a good understanding of this information, and you need to be available to answer their questions.
If you develop an unsteady gait, blurred vision, or decreased urine output, contact your provider or go to the hospital immediately. These are signs of severe lithium toxicity.
That sounds scary. I'm not sure I want to take this medication.
Lithium is an effective medication for bipolar disorder, Susan. If you can recognize early signs of toxicity, you can avoid getting to that point. Do you have any questions about lithium side effects, toxicity, or managing any other aspect of your bipolar disorder?
No, I think I understand.
I noticed that Dr. Price is planning for your discharge in about a week.
Oh, that's great. I'll be ready by then. Are you ready? Yes. I just want to thank you, Ben, for all your care, instructions, and helpful information. I think we're well prepared to help Susan readjust to home and get back to her job, at least on a part-time basis.
I wish you all the best. Susan, you have made excellent progress here over the past 8 days. Remember to call at any time if you have any questions.
Thank you so much, Ben, for everything.
I'm really sorry to hear that, Dr. Price. We'll be expecting her within the hour. Thanks. Ben, Susan Choi is being readmitted. This is her 5th admission in the past 13 months, and now Dr. Price is admitting her again. Unfortunately, last night, Susan attempted suicide. She is really depressed and socially withdrawn.
Let me see if Dr. Price already entered prescriptions for Susan. Yeah, and he wants her on suicide precautions. I'll review the assessments that were done just prior to his hospitalization.
Great, thanks, man.
Hey Ben, I was wondering, if so many people attempt suicide each year, how does the provider make a decision when to hospitalize a client? Hey Ben, I was wondering, if so many people attempt suicide each year, how does the provider know when to make a decision to hospitalize a client?
Well, there are lots of assessment tools available for various purposes. Do you remember using the CWA the other day for the initial screening of your client showing symptoms of alcohol withdrawal? We also use the CAGE to assess a client's addiction to alcohol or drugs. Then there's another tool to assess suicide risk factors.
Wasn't she taking some medication to stabilize her mood?
Well, I'll need to go back and review her history when she arrives. Oh, Eva, I remember now. Susan started taking lamotrigine after her second readmission to her unit for acute mania.
Lamotrigine, isn't that given to treat seizures?
Yes, it is. It's an anti-epileptic. But clients who have rapid cycling also take it for mood stabilization when lithium is not enough.
Remind me what rapid cycling is.
That term refers to 4 or more mood episodes in a 12-month period and indicates that a client has severe symptoms that don't respond to standard pharmacological treatment. Lamotrigine carries the risk of a very serious adverse effect. Yes, Stevens-Johnson syndrome is potentially fatal, but fortunately a very rare adverse effect of lamotrigine. One of the first indications of this syndrome is a rash.
Okay, thanks for clarifying this information.
You're welcome. Well, it looks like Susan's here. I need to go spend some time with her. Susan, you've been looking down and turning away from me during my time here this morning. Tell me how you're doing.
It is me shivering all over.
Susan, are you having thoughts about taking your own life?
Yes, that's all I think about. I just don't see how I can go on. I just feel like I'm in a big, dark, black hole.
Ben, I just noticed something in your nurse's notes that concerned me. Susan told you yesterday morning that she wanted to end her life, but you failed to follow up with a lethality assessment and ask her if she had a plan. After you left yesterday, Susan ingested a bottle of acetaminophen that we did not know she had. She's now in the ICU. Okay, that's fine, thank you. Hey Ben, you're getting an admission in the next 15 minutes, coming from the outpatient clinic.
Okay, what can you tell me about this line?
Well, Susan Choi is 33 years old. She's been followed for depression over the past 6 months and is being admitted for acute mania. She's on administrative leave from her employer. She's a public accountant. She's single and resides in her parents' home. Her behavior has become very unpredictable, so her mother brought her into the clinic to see Dr. Price.
Is she taking any medications?
She started on fluoxetine 20 milligrams a day, but her provider recently increased the dosage to 20 milligrams twice a day, so her provider doubled the dose. She is being admitted for evaluation and stabilization.
Okay, I'll make sure the room is ready.
Great, thanks, Ben.
Yeah, this is Susan. Okay, thanks, Andrew. You bet. Hi, Susan. And you are?
Just Danny. Mrs. Choi, Susan's mother. You can call me Mrs. Choi.
Okay, Susan. I'm going to spend some time getting to know you. Let's see. Your date of birth is
33 years old. Born February 22nd.
okay. So before we go to the conference room, we're going to stop in the treatment room so I can get your vitals. I'll show you to your room later. Your vital signs look fine, Susan. From the information I have here, you've been treated for depression and done well for quite some time. But now you are having problems focusing, such as eating,
I'm
sleeping.
doing great. Better. I can obviously my knee. Squats is a drug.
I see your provider is Dr. Price.
Dr. Price is a jewel. Price is right. He's bright. He says I'm all right. He knows I'm the morning light. I don't need to be here. You need to save the bed for someone who's really sick.
Mrs. Choi, do you recall any history of depression or mania in your family?
No, nothing like this. Back in South Korea, my father went through a dark depression, but I think it was related to the financial loss of the bad business deal. We lost all our savings. And that was a long time ago. Quite a mess.
Many families question if genetics is a factor in the development of bipolar disorders. That's why I think it's important to provide this information.
Everything's important. I'm important. Don't you as you are important too? And can I tell you about all the important things I have to do?
I know thoughts are racing through your mind, Susan. You'd like to take some steps to help you slow down, eat better, and sleep through the night. Let's all head to your room. Okay, Susan, here's your room.
It could be your room too, Ben. I'd like to give to another. This is a wild thing. You make my bells ring. Oh, Susan, please. I tried, Ben, but I can't stop touching you. I'll try again.
You need to do more than try. There's a no touching policy on this unit, and you need to stop now. Other nurses are going to remind you as well. Now, Mother brought you some clothes. They're here in the suitcase. Why don't you change into something more comfortable? Once you change your clothes, I'll return to give you some medication that Dr. Price prescribed for you.
The price is right. Hi, Ben. Is that medication for Susan Choi? What are you giving her?
This is olanzapine, 10 milligrams IM. There's a prescription from Dr. Price to administer it stat, and Susan really needs this medication.
Olanzapine is an antipsychotic. Doesn't Susan have a bipolar disorder? Won't she also take lithium?
Yes, the plans are to have Susan start on lithium therapy, possibly tomorrow. Lithium takes 7 to 14 days to have a calming effect on clients. So, a client with acute mania can receive an antipsychotic medication like olanzapine to prevent exhaustion, coronary vascular collapse, and death.
Wow, I forgot how serious acute mania can be. Thanks for reminding me about the expected outcomes.
You're welcome. Could you check this medication calculation? I had to reconstitute it and would like to have you double check it for accuracy.
Sure, let me see.
Okay, Susan. I'd like you to meet Eva, one of the other nurses on our unit. I have the medication that Dr. Price prescribed for you. This is Troy. Just step out now.
What's that? I'm not taking that. I don't need it. I take my pills. Get her out of here right now!
Susan, let's talk about why Dr. Price prescribed this medication.
I'm easy. Doctor's hot. Talk to me if you want, but I'm not going to take a shot.
Receiving the medication by injection will help you feel better quickly. Afterward, you can continue to take your oral medication.
So you think this is going to help?
I think you will feel a lot better if you would allow us to give it to you now.
Okay, I guess. If Dr. Price thinks it is going to help.
Does anyone have anything to add to that?
Hello, everybody. What's going on in here?
Susan, this is group time. Mary, these things don't walk the hall and show around the unit.
I'd be glad to. Where are we going? Since this is your first day, I'm going to show you around the unit. We want you to feel welcome in the new environment.
Okay, cool.
Jan, Susan and Mrs. Troy, Dr.
We need to develop a consistent.
Okay. If you develop
Are you ready? I'm really sorry to hear.
Eva, I remember now. Susan started taking land. Yes, Stevens Johnson. Susan. Eva.
I did take a bottle of acetaminophen. What's wrong?
Susan is still so depressed and continues to talk about wanting to die. But I see that Dr. Price wants to initiate electroconvulsive therapy tomorrow morning. It's been a while since I've prepared a client for an ECT. Do you have any tips?
Well, remind her to empty your bladder before you give the glycopyrrolate to drive her oral secretion. Oh, and put her on the cardiac monitor. Also, glycopyrrolate could make Susan dizzy, drowsy, and even cause blurred vision, so you wouldn't want to get her up.
That's right. Thanks for the tips. Even though Susan takes lithium and lamotrigine, she may benefit from ECT too. I've seen lots of clients who have experienced rapid cycling and who haven't responded optimally to medications make significant improvements with ECT.
Yes, I've seen the same response from many of my clients too.
Okay, Susan, do you feel like you're ready to go home?
I think I am.
Good. I know we have discussed some of this before, but I want to reinforce the ways you can successfully manage your health as you return home today.
I'm always happy to review the steps to keep Susan healthy and keep her out of the hospital.
In addition to the prescription for lithium and lamotrigine, there are other ways to support your recovery.
Spanish planning discharge outcomes for Susan Choi. Identify client outcomes for Susan in the following areas: lifestyle support, bipolar management, medication management, and crisis management.
Lifestyle support, bipolar management. Client will 1. Review educational material about bipolar disorder and its management. 2. Maintain consistent patterns in sleep, meals, and activities. 3. Identify strategies for enhancing communication and problem-solving skills. 4. Recognize support systems at home.
We'll make some room. And we'll start off with the side.
5. Carry names and contact information for local bipolar support groups, such as the National Alliance for the Mentally Ill and the Depression and Bipolar Support Alliance. 6. Attend or follow up appointments. Medication management. Client will 1. Review educational materials related to current medications, lithium and lamotrigine. 2. Carry personalized medication card, which identifies current prescribed medications. 3. Take prescribed medication, even when feeling well. 4. Identify dietary and lifestyle management related to medications. 5. Describe the expected side effects and signs of toxicity of medications. 6. Identify steps to take if toxicity or adverse effects of medication occur. 7. Keep all appointments for regular monitoring of blood lithium levels. Crisis management. Client will 1. Identify signs of bipolar relapse and possible precipitating factors. 2. Develop a safety plan to manage relapse symptoms. 3. Identify possible emergency situations that necessitate calling 911.
2, 3, 4, 5, 6, 7, 8, 9, 10. Shake it up. Take a big inhale. You're about to do the figure 4. One leg over the other. We're going to push down on our knee. Down. 1, 2, 3, 4, 5, 6, 7, 8, 9, Switch sides, other leg up, push down. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Grab a seat. We'll do the teapot stretch. So, hug your fist. We're gonna put our fist on the wall or whatever surface is behind you. Go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Switch sides. Other hand out, 90 degree angle. Try to reach the surface. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. We'll do the butterfly stretch. So, for those who don't know, put your feet together like this. And we're going to hold it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We'll do the mountain stretch. Slowly climb up the mountain, one leg over the other, interlock your fingers, your thigh, then bend forward. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Here's the fun part. Just droop down your leg. Climb back up with the other leg. Interlock your fingers, bend forward. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then, and we'll do the frog stretch. So we're going to put 2 knees on the ground, hold like a plank position, and this will help stretch out our groin. Now, 1, 2, 3, 4, 5, 6, 7, 8, 9. Alright. Good job. Let's grab a seat. Do some nice stretches there. We'll start with our side bends. Left side. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Switch sides. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. The wingspan. Try to touch your fingers. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Switch sides. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Neck rotation left side. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Switch sides. 1, 2.
Lifestyle support. Client will review education material about bipolar disorder and its management. Maintain sleep patterns and sleep, meals, and activities. The client will recognize support from staff, family, friends. Medication management. The client will review educational materials related to current medication. The client will have an understanding of the prescribed medications. Client will take medications as prescribed and identify dietary and lifestyle management. Crisis management. Client will identify signs of bipolar relapse and possible precipitating factors. The client will be helped to develop a safety plan and identify possible emergency situations that necessitate calling 911.
Forward. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then we'll do the shoulder blade pull. Hit your fist, draw it back.
Thank you.
1,
Excuse
2,
me. You may remember me. I'm Susan Choi.
5,
Susan,
6,
it's so good to see you.
8,
You're looking great.
9.
Thank you. I just wanted to stop by and thank you for helping me in my recovery.
Oh, that is nice.
I'll be right
How are
back.
you doing?
I'm doing so much better now. I just started volunteering 2 days a week at the local chapter of a well-known mental health organization.
Wow,
Yeah, it feels good to work again and help others.
that is such a good idea. You really do have a lot to offer.
Well, thank you. I just brought this to thank you for helping me get my life back.
Guys, I repent. I have a late assignment that is probably not going to be accepted. And I'm still going to turn it in. To do it 9:59. I have to become better, guys. Real life RN mental health bipolar disorder. I'm turning this assignment, but it is late. And I understand that it will not be accepted. Okay, so guys, I just turned in this assignment.
That was good. Batteries are recharged, isn't it? I'm glad you enjoyed it. Alright, let's zoom back in for another session. We're going 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good luck, guys, and have a great session.
Okay, guys, I'm going to finish this chapter. Chapter 16.
Dissociative disorders. Dissociative disorders occur after significant adverse experiences, traumas, and individuals respond to stress with a severe interruption of consciousness. Dissociation is an unconscious defense mechanism that protects the individual against overwhelming anxiety through an emotional separation. However, this separation results in disturbances in memory, consciousness, self-identity, and perception. Patients with dissociative disorders have intact reality testing. This means that although the person may have flashbacks or images, these are triggered by current events, relate to the past trauma, and are not delusions or hallucinations. Mild fleeting dissociative experiences are relatively common to all of us. For example, we say we are on autopilot when we drive home from work and cannot recall the last 15 minutes before reaching the house. These common experiences are distinctly different from the processes of pathological dissociation. Dissociation is involuntary and results in failure of the normal control over a person's mental processes and normal integration of conscious awareness. Dimensions of a memory that should be linked are not ever fragmented. For example, a person may be aware of a sound or smell, but these sensations would not be linked to the actual event itself, leaving the person fearful and/or confused. In addition, the person may reenact, as well as re-experience, trauma without consciously knowing why. Symptoms of dissociation may be either positive or negative. Positive symptoms refer to unwanted additions to mental activity such as flashbacks. Negative symptoms refer to deficits such as memory problems or the ability to sense or control different parts of the body. Dissociation decreases the immediate subjective distress of the trauma and also continues to protect the individual from full awareness of the disturbing event. Dissociation can also be somewhat protective for a child to maintain an attachment with abusive or neglectful caregivers. This highlights the importance of attachments and relationships in allowing the child to grow socially, intellectually, and cognitively. If abuse or neglect has occurred, these memories become compartmentalized and often do not intrude into awareness until later in life when the person is in a stressful situation. Dissociative disorders include 1. Depersonalization derealization disorder, 2. Dissociative amnesia, and 3. Dissociative identity disorder. Depersonalization derealization disorder. Depersonalization derealization is found in both adolescents and adults, often in response to acute stress. In depersonalization, the focus is on oneself. It is an extremely uncomfortable feeling of being an observer of one's own body or mental processes. In derealization, the focus is on the outside world. It is the recurring feeling that one's surroundings are unreal or distant. The person may feel mechanical, dreamy, or detached from the body. Some people suffer episodes of these problems that come and go, while others have episodes that begin with stressors and eventually become constant. Patients describe these experiences as very distressing. Vignette. Elizabeth, a 42-year-old executive, gasps as she looks in the mirror. She can't believe the changes in her appearance. She thinks that her body looks wavy and out of focus. She says that it feels as though she is floating in a fog and her feet are not actually touching the ground. I wonder if I am really awake or if my life is a dream. As she is admitted to the stress management unit, Elizabeth confides to the nurse that her son has recently been charged with insider trading in the stock market and that he may be facing a lengthy jail sentence. Dissociative amnesia. Dissociative amnesia may occur in any age group from children to adults. The amnesia is often related to trauma, and memory usually returns spontaneously after the individual is removed from a stressful situation. ISSTD, 2012. Dissociative amnesia is marked by the inability to recall important personal information, often of a traumatic or stressful nature. The amnesia may also be localized. The patient is unable to remember all events in a certain period, or selective. The patient is able to recall some but not all events in a certain period. A subtype of dissociative amnesia is dissociative fugue. It is characterized by sudden unexpected travel and an inability to recall one's identity and information about some or all of the past. In rare cases, an individual with dissociative fugue assumes a whole new identity. In fugue states, individuals often function adequately in their new identities by choosing simple, undemanding occupations and having few intimate social interactions. After a few weeks to a few months, they may remember their former identities and then become amnesic for the time spent in the fugue state. Usually, a traumatic event precedes a dissociative fugue. Vignette. A young woman found wandering in a Florida park is partly dressed and poorly nourished. She has no knowledge of who she is. Her parents identify her 2 weeks later when she appears in an interview on a national television show. Her boyfriend of 3 years had committed suicide before the fugue state. Dissociative identity disorder. The essential feature of dissociative identity disorder is the presence of 2 or more distinct personality states that frequently take control of behavior. Each alternate personality alter has its own pattern of perceiving, relating to, and thinking about the self and the environment. It is believed that severe sexual, physical, or psychological trauma in childhood predisposes an individual to the development of dissociative identity disorder. Dissociative identity disorder is associated with at least 2 dissociative identity states. One is a state or personality that functions on a daily basis and blocks access and responses to traumatic memories, and another state, also referred to as an alter state, is fixated on traumatic memories. Each alter is a complex unit with its own memories, behavioral patterns, and social relationships that dictate how the person acts when that personality is dominant. Often the original or primary personality is religious and moralistic, and the alters are pleasure-seeking and non-conforming. The alter personalities may behave as individuals of a different sex, race, or religion. The dominant hand and the voice may also be different. Intelligence and electroencephalographic findings may also be altered. The primary personality or host is usually not aware of the alters and is perplexed by lost time and unexplained events. Experiences such as finding unfamiliar clothing in the closet, being called a different name by a stranger, or not having childhood memories are characteristic of dissociative identity disorder. Alters may be aware of the existence of each other to some degree. Transition from one personality to another switching occurs during times of stress and may range from a dramatic to a barely noticeable event. Some patients experience the transition when awakening. Shifts may last from minutes to months, although shorter periods are more common. Several movies and TV shows that explore case studies of individuals diagnosed with dissociative identity disorder have been produced. They include Sybil 1976, The 3 Faces of Eve 1957, Fight Club 1999, Me, Myself and Irene 2000, and the television series The United States of Terror. Epidemiology. The lifetime prevalence of dissociative disorders ranges from 2% to 10%. International Society for the Study of Trauma and Dissociation, ISSTD, 2012. Depersonalization derealization disorder is about 2%. Females and males are equally affected by this problem. Dissociative amnesia is also fairly common with a prevalence of about 2% to 7%. Females are affected at more than twice the rate of men. Dissociative identity disorder has a 12-month prevalence of 1.5%. Males and females are equally represented in this disorder. Comorbidity. Comorbidity is common with dissociative disorders. Major depressive disorder, panic attacks, eating disorders, PTSD, somatoform symptoms, eating disorders, obsessive compulsive disorder, OCD, reactive attachment disorder, and attention deficit disorder commonly co-occur with the dissociative disorders. Personality disorders such as borderline personality disorder, substance use disorders, and sexual and sleep disorders are also comorbid with dissociative disorders. ISSTD 2012. Dissociative amnesia may be comorbid with conversion disorder or personality disorder. Dissociative fugue may co-occur with PTSD. Depersonalization and derealization also occur in hypochondriasis, mood and anxiety disorders, obsessive compulsive disorder, and schizophrenia. Risk factors. Childhood physical, sexual, or emotional abuse and other traumatic life events are associated with adults experiencing dissociative symptoms. Dissociative symptoms, or NIMP-like, actually reduce disturbing feelings and protect the person from full awareness of the trauma. Biological factors. Genetic. Although genetic variability is thought to play a role in stress reactivity, dissociation is largely due to extreme stress or environmental factors. Neurobiological. The limbic system is involved in the development of dissociative disorders. Animal studies show that early and prolonged detachment from the caretaker negatively affects the development of the limbic system. Traumatic memories are processed in the limbic system, and the hippocampus stores this information. Individuals with dissociative disorders have altered communication between higher and lower brain structures due to the massive release of endogenous opioids at the time of severe threat. This inhibits the thalamus from connecting with the limbic area with the neocortex and integration across the hemispheres through the corpus callosum. Lanius et al. 2014. People with temporal lobe epilepsy experience depersonalization, derealization, anxiety, and dissociation. This overlap of symptoms results in people without epilepsy being treated with anticonvulsants. Conversely, but less likely, people with epilepsy may be treated for a psychiatric disorder. Psychological factors. One of the most primitive ego defense mechanisms is dissociation. The theory of structural dissociation of the personality proposes that patients with complex trauma have different parts of their personality, the apparently normal part and the emotional part, that are not fully integrated with each other. Steele et al. 2005. Each part has its own responses, feelings, thoughts, perceptions, physical sensations, and behaviors. These different parts may not be aware of one another with only one dominant personality operating depending on the situation and circumstance of the moment. Environmental factors. Dissociative disorders are responses to acute overwhelming trauma and as such are due to environmental factors. These may include any experience that is overwhelming to the person such as a motor vehicle accident, combat, emotional verbal abuse, incest, neglectful or abusive caregivers, imprisonment, and many other types of traumatic events. Cultural considerations. Certain culture-bound disorders exist that are similar to dissociative fugue. They are characterized by a high level of activity, a trance-like state, and running or fleeing, followed by exhaustion, sleep, and amnesia regarding the episode. These syndromes include Kidwato seen in native people of the Arctic, frenzy witchcraft among the Navajo, and among Western Pacific natives. These syndromes, if observed in individuals native to the corresponding geographical areas, are different from dissociative disorders, and the nurse should take this into account. Icon. Considering culture. Are culture-bound syndromes always culture-bound? The DSM-5 identifies syndromes specific to certain cultures. Some syndromes have predominantly dissociative syndromes. For example, attack interbios occurs among individuals of Latino descent. It is characterized by acute anxiety, anger, grief, shouting, crying, trembling, and heat in the upper part of the body. The person may become verbally and physically aggressive. Dissociative episodes such as depersonalization, derealization, amnesia, seizures, and fainting also can occur. An interesting study included 100 mainly white inpatients in the United States with a history of childhood and/or sexual abuse 87% and dissociative disorders 73%. Researchers found that many symptoms that tend to be considered culture-bound occurred with surprising frequency in these patients. Participants reported that they were possessed and were involved with various exorcism procedures. Among the procedures were having a healer enter a trance state during a ritual, animal sacrifice, or ritual dancing. The most common exorcism practice involved prayer, which is consistent with mainstream Christian beliefs. The authors conclude that not all classical culture-bound syndromes are really culture-bound. Dissociative symptoms are similar no matter the culture. Referring to dissociative symptoms as a unique cultural syndrome may be an epidemiological error and one based on American and DSM ethnocentricity. Ross, C., Schroeder, B.A., and Ness, L. 2013. Dissociation and symptoms of culture-bound syndromes in North America, a preliminary study. Journal of Trauma and Dissociation, 14, 224 to 235. Application of the nursing process. Assessment. Many patients with dissociative disorders seek help for depressive and anxiety disorder. Living with symptoms such as feeling unreal, perceiving as unreal, forgetting significant events, and losing track of time are obviously disturbing and depressing. Specific information about life events, memory, suicide risk, and the impact of the disorder on the patient and the family are important dimensions to assess. Life events. The nurse gathers information about events in the person's life. Has the patient sustained a recent injury such as a concussion? Does the patient have a history of epilepsy, especially temporal lobe epilepsy? Does the patient have a history of early trauma such as physical, mental, or sexual abuse? If you suspect dissociative identity disorder, ask the following questions. 1. Have you ever found yourself wearing clothes you cannot remember buying? 2. Have you ever had strange persons read and talk to you as though they were old friends? 3. Does your ability to engage in things such as athletics, artistic activities, or mechanical tasks seem to change? 4. Do you have differing sets of memories about childhood? Memory. The nurse should consider the following when assessing memory. 1. Can the patient remember recent and past events? 2. Is the patient's memory clear and complete or partially fuzzy? 3. Is the patient aware of gaps in memory such as lack of memory for events such as a graduation or a wedding? 4. Do the patient's memories place herself with a family, in school, or in occupation? 5. Is the patient oriented to time, place, person, and situation? 6. Does the patient ever lose time or have blackouts? 7. Does the patient ever find herself or himself in places with no idea how she or he got there? Suicide risk. Whenever a patient's life has been substantially disrupted, the patient may have thoughts of suicide. Nurses should be alert for expressions of hopelessness, helplessness, or worthlessness. Directly addressing the possibility of suicidal ideation, intent, and plans are always important interventions when working with this population. Asking questions for self-mutilating compulsions and behaviors is important, as is directly assessing for physical harm since dissociative patients may be unaware of injury. Impact on patient and family. Dissociative disorders impair an individual's ability to relate to the world, which results in significant impairment of interpersonal relationships. Feelings of being unreal or the world being unreal negatively impact normal communication patterns and satisfaction in relationships. Patients with depersonalization, derealization disorder are often fearful that others may perceive their appearance as distorted and may avoid being seen in public. Patients with dissociative amnesia and identity disorder often have employment and family problems. Memory loss often renders them unable to work and impairs normal relationships. Employees dislike the lost time that may occur due to dissociative symptoms. Families often direct considerable attention toward the patient but may express concern over having to assume roles that were once assigned to the patient. Families find it difficult to accept the seemingly erratic behaviors of the patient. The high anxiety that accompanies dissociative disorders makes it difficult to keep relationships stable. Assessment tools. Reviewing assessment tools can help you remember the symptoms of dissociation and to understand what your patient is experiencing. Scales have been developed to assess dissociation. The Cambridge Depersonalization Scale. Sierra and Berrios, 2000 measures both depersonalization and derealization. General dissociation is assessed with the dissociative experience scale DES. Bernstein and Putnam, 1986, and the Somatoform Dissociation Questionnaire, SDQ. Ninhouse et al. Suicide risk. Whenever a patient's life has been substantially disrupted, the patient may have thoughts of suicide. Nurses should be alert for expressions of hopelessness, helplessness, or worthlessness. Directly addressing the possibility of suicidal ideation, intent, and plans are always important interventions when working with this population. Asking questions for self-mutilating compulsions and behaviors is important, as is directly assessing for physical harm since dissociative patients may be unaware of injury. Impact on patient and family. Dissociative disorders impair an individual's ability to relate to the world, which results in significant impairment of interpersonal relationships. Feelings of being unreal or the world being unreal negatively impact normal communication patterns and satisfaction in relationships. Patients with depersonalization, derealization disorder are often fearful that others may perceive their appearance as distorted and may avoid being seen in public. Patients with dissociative amnesia and identity disorder often have employment and family problems. Memory loss often renders them unable to work and impairs normal relationships. Employees dislike the lost time that may occur due to dissociative symptoms. Families often direct considerable attention toward the patient but may express concern over having to assume roles that were once assigned to the patient. Families find it difficult to accept the seemingly erratic behaviors of the patient. The high anxiety that accompanies dissociative disorders makes it difficult to keep relationships stable. Assessment tools. Reviewing assessment tools can help you remember the symptoms of dissociation and to understand what your patient is experiencing. Scales have been developed to assess dissociation. The Cambridge Depersonalization Scale. Sierra and Berrios, 2000 measures both depersonalization and derealization. General dissociation is assessed with the dissociative experience scale DES. Bernstein and Putnam, 1986, and the Somatoform Dissociation Questionnaire, SDQ. Ninhouse et al., 2012. Both are available online. General guidelines for assessment. General guidelines for assessment of a patient with a dissociative disorder include: 1. Assess for a history of self-harm. 2. Evaluate level of anxiety and signs of dissociation. 3. Identify support systems through a psychosocial assessment. 4. Refer patient to therapist. Self-assessment. It is natural to experience feelings of discomfort when working with people who lose self-awareness. You may simply be skeptical that someone could forget who they are and believe that they are being manipulative and want to leave their responsibilities behind. On the other hand, some nurses experience feelings of fascination and are caught up in the intrigue of caring for a patient with these dramatic disorders. Self-awareness, managing overly negative or positive responses, and recognizing professional boundaries are essential skills when working with this population. Diagnosis. C. Table 16.1 for potential nursing diagnoses. Outcomes identification. The overall goal for dissociative disorder is to develop an integrated and complete perception of self. C. Table 16.1 for possible short-term outcomes for dissociative disorders. Table 16.1. Signs and symptoms, diagnoses, and outcomes for dissociative disorders. Signs and symptoms. Nursing diagnoses. Outcomes. Amnesia or fugue related to a traumatic event, symptoms of depersonalization, feelings of unreality, and or body image distortions. Disturbed personal identity. Verbalizes clear sense of personal identity, perceives environment accurately, performs social roles well. Alterations in consciousness, memory, or identity, abuse of substances, disorganization or dysfunction in usual patterns of behavior, absence from work, withdrawal from relationships, changes in role function. Ineffective role performance. Performs family, parental, intimate, community, and work roles adequately, reports comfort with role expectations, recovers deficits in memory. Feeling of being out of control of memory, behaviors, and awareness, inability to explain actions or behaviors when in altered state. Anxiety, self-control. Monitors intensity of anxiety, identifies triggers that lead to switching, uses effective coping strategies to manage anxiety. From Erdman, T.H., and Kamatsu, S. eds. 2014. Nursing Diagnoses, Definitions and Classification 2015-2017. Oxford, UK, Wiley Blackwell. Copyright 2014, 1994-2012 by Nando International. Used by arrangement with John Wiley & Sons Limited, Moorhead, S. Johnson, M. Mars, M.L. and Swanson, E. 2013. Nursing Outcomes Classification, NOC, 5th ed. St. Louis, Mo. Mosby. Planning. The setting and presenting problem influence the planning of nursing care for the patient with a dissociative disorder. However, a phase-oriented treatment model is recommended and includes the following. Phase 1, establishing safety, stabilization, and symptom reduction. Phase 2, confronting, working through, and integrating traumatic memories. Phase 3, identity integration and rehabilitation. The nurse will most often encounter the patient in times of crisis, i.e., when the patient is admitted to the hospital for suicidal or homicidal behavior. The care plan will focus on phase 1 strategies to ensure safety and crisis intervention. The patient may also come for treatment of a comorbid depression or anxiety disorder in a community setting. Planning will address the presenting complaint with appropriate referrals for treatment of the dissociative disorder. Implementation. Healing trauma can be thought of as a process of integration and linking neural networks that have become disconnected during an overwhelming event. You should offer an emotional presence during the recall of painful experiences, provide a sense of safety, and encourage an optimal level of functioning. NIC topics that offer relevant interventions include anxiety reduction, coping enhancement, self-awareness enhancement, self-esteem enhancement, and emotional support. Refer to Table 16.2 for examples of basic level interventions. Psychoeducation. Patients with dissociative disorders need to learn about their illness and be given ongoing instruction about coping skills and stress management. Normalizing experiences by explaining symptoms as adaptive responses to overwhelming events is important. Often the victim of childhood trauma grows up with the false negative belief that the abuse was deserved punishment. Grounding techniques promote the individual's ability to be in the moment and help counter dissociative episodes. For example, dissociation can be disrupted by stomping feet, taking a shower, holding an ice cube, exercising, deep breathing, or touching the upholstery on a chair. Patients can learn to keep a daily journal to increase awareness of feelings and to identify triggers to dissociation. If a patient has never written a journal, the nurse should suggest beginning with a 5 to 10 minute daily writing exercise. Pharmacological interventions. There are no specific medications for patients with dissociative disorders, but appropriate medications are often prescribed for the hyperarousal and intrusive symptoms that accompany PTSD and dissociation. ISSDD 2012. These might include antidepressant medication, anti-anxiety agents, and antipsychotics. Substance use disorders and suicidal risk, which are common, must be assessed carefully in selecting safe and appropriate pharmacotherapy. In the acute setting, the nurse may witness dramatic memory retrieval in patients with dissociative amnesia or fugue after treatment with intravenous benzodiazepines. Advanced practice interventions. Advanced practice psychiatric mental health registered nurses use therapies discussed previously, CBT and modified EMDR. Other therapies that may be useful with dissociative conditions include psychodynamic psychotherapy, exposure therapy, hypnotherapy, neurofeedback, ego state therapies, and somatic therapies. Table 16.2. Basic level nursing interventions for dissociative disorders. Intervention. Rationale. Provide undemanding, simple routine. Reduces anxiety. Ensure patient safety by providing safe, protected environment and frequent observation. Sense of bewilderment may need to give attention to safety needs. Some alters may be thrill-seeking, violent, or careless. Confirm identity of patient and orientation to time and place. Supports reality and promotes ego integrity. Encourage patient to do things for self and make decisions about routine tasks. Enhances self-esteem by reducing sense of powerlessness and reduces secondary gain associated with dependence. Assist with major decision-making until memory returns. Low stress and prevents patient from having to live with the consequences of unwise decisions. Support patient during exploration of feelings surrounding the stressful event. Helps lower the defense of dissociation used by patient to block awareness of the stressful event. Do not flood patient with data regarding past events. Provide support through empathetic listening during disclosure of painful experiences. Can be healing while minimizing feelings of isolation. Teach patient grounding techniques such as taking a shower, deep breathing, touching fabric on chair, exercising or stomping feet. Helps keep the person in the present and decrease dissociation. Accept patient's expression of negative feelings. Conveys permission to have negative or unacceptable feelings. Teach stress reduction methods. Provides alternatives for anxiety relief. If patient does not remember significant others, work with involved parties to re-establish relationships. Helps patient experience satisfaction and relieve sense of isolation. Somatic therapy. Dissociation causes people to experience a distressing fragmentation of consciousness and a sense of separation from themselves. Disturbances of perception, sensation, autonomic regulation, and movement are common for those who have suffered significant trauma because trauma is often stored physically in the body. Verbal and psychotherapies are seen as complementary by the discipline of dance movement therapists in working with traumatized dissociative patients in emotional recovery. Gosh and Harvey, 2012. Sensory motor psychotherapy combines talk therapy with body-centered interventions and movement to address dissociative symptoms. Ogden et al., 2006. This therapy is based on the premise that the body, mind, emotions, and spirit are interrelated, and a change at one level results in changes in the others. Awareness, focusing on the present, and recognizing touch as a means of communicating are some of the principles of this therapy. During psychotherapy sessions, the patient describes current physical sensations. The goal is to safely disarm the pathological defense mechanism of dissociation and replace it with other resources, especially body awareness and mindfulness. Evaluation. Overall, treatment effectiveness for dissociative disorders is evaluated by integration. In general, treatment for dissociative disorders is considered successful when outcomes are met. In the final analysis, the evaluation is positive when 1. Patient safety has been maintained. 2. Anxiety has been reduced and the patient has returned to a functional state. 3. Integration of the fragmented memories has occurred. 4. New coping strategies have permitted the patient to function at a better level. 5. Stress is handled adaptively without the use of dissociation. Key points to remember. Childhood trauma changes the brain and can cause medical and psychological problems in adulthood. A phase model of treatment is most effective with safety and stabilization first. Evidence-based treatments for trauma are movement desensitization and reprocessing EMDR therapy and cognitive behavioral therapy, CBT. Understanding patients as traumatized changes the conversation from what is wrong with this person to what happened to this person. Trauma is stored in the body and often manifests as physical symptoms. Healing involves connection and integration. Dissociative disorders involve a destruction in consciousness with significant impairments in memory, identity, and perception of self. Assessment is especially important in clarifying the history of symptoms and obtaining a complete picture of the current physical, psychological, and safety status. Psychotherapy is the treatment of choice for trauma, with medication prescribed only to ameliorate symptoms. Patients with trauma-related disorders are often treated on an outpatient basis except during a period of crisis such as suicidal risk. Crisis intervention is important for stabilization. Referral for psychotherapy to attain sustained improvement in level of functioning is typically necessary. Critical thinking exercises. 1. Jean is a 48-year-old with dissociative identity disorder who was admitted to the crisis unit for a short-term stay after a suicide threat. On the unit, she has repeated the statement that she will kill herself to get rid of all the others, meaning her alters. A. How do you think that staff reacts to working with patients such as Jean? B. What do you believe needs to be done to protect Jean? 2. Stephen is an 8-year-old who was in a devastating earthquake and came to the outpatient clinic with his parents because he was having nightmares and trouble sleeping. How would you explain what is happening to Stephen? 3. John, a 24-year-old, returned from the Iraq War last month. Since then he has become increasingly irritable, isolated, and depressed. His wife says he does not want to go anywhere and won't leave his home for days at a time. In the interview with the nurse at the clinic, he indicates that he feels helpless and anxious and jumpy. A. Identify priorities in providing care for this patient. B. What type of medication would you anticipate being ordered for John? Chapter review. Questions. 1. Which statement made by the patient demonstrates an understanding of the treatment of choice for patients managing the effects of traumatic events? A. I attend my therapy sessions regularly. B. Those intrusive memories are hidden for a reason and should stay hidden. C. Keeping busy is the key to getting mentally healthy. D. I've agreed to move in with my parents so I'll get the support I need. 2. Which goal should be addressed initially when providing care for 10-year-old Harper, who is diagnosed with post-traumatic stress disorder (PTSD)? A. Harper will be able to identify feelings through the use of play therapy. B. Harper and her parents will have access to protective resources available through social services.
Okay, guys. So I have just did my reading for Module 2, and I have, of course, reading is a lifestyle. It's not something that you just do in one day and then you're done with it. Reading is a lifestyle. If you want to change the way you think, you're going to have to read. You're going to have to learn to just practice your basic skills of reading, writing, and learning how to just so Yeah, so I'm going to be entering into Somatic System Disorders by Lois Angelo. So I'm going to be, soma is the Greek word for body. Somatization is the expression of stress through physical symptoms. These symptoms may be manifestation of psychological and emotional distress. So I'm going to be learning about the disorders that affect the body. Then chapter 18 is going to go into eating and feeding disorders. So that's going to be anorexia nervosa. I'm going to go over the planning, implementations, evaluation. Then I'm going to go into the different diagnoses, learning about it, binge eating disorders. I'm going to also review feeding disorders, pica, rumination disorders. And then I think it goes into chapter 19, but let me just double check. One moment, I'm checking now. Okay, so just going to my reading list. Okay, so 1718, which is the eating and feeding disorders, and it's going to be chapter 22, which is substance-related and addictive disorders. Okay, then chapter 23, neurocognitive disorders, and then chapter 24, which is personality disorders. So I'm going to be reading those chapters, but I have to do some chores, guys. So you guys are going to come with me, and I got to fold some clothes. I got to put some clothes in the washer. So, yes. There's a lot I have to do. Once again, this is Woon Jin Chow. I've been doing a study porama with him. He's great, guys. If you want to learn how to study, check out his channel. All right, so I'm going to keep that plan. I'm going to go put some clothes in the washer. All right, guys. So my shed is a little dirty. I got to get it organized. All right. So this is my shed here. What I got left to do is basically, those are my covers for my bed. So that's what I'm going to be doing next, is just washing like the clothes for my bed. Let me see. I don't think I started these yet. Or did I? I'm just going to wash them again. I'm not sure if I have washed those clothes yet. But I'm going to wash them again. Just to make sure. Alright, then I'm going to be focusing on cleaning my bread. So this is done. I'm using the Hypoallergenic ECOS plant-powered laundry detergent. It's Magnolia and Lily. So this was okay. It's safer, powerful, sustainable. Only 7 ingredients: water, cocoa madrophil, bedtime, sodium, cocoa sulfate, cocoa madrophilooxidine, phenyloxidine fragrance, and methyl lysotose preservative. So it was pretty good, but I'm a game girl, y'all. I'm a game girl. So then I've also was using the Downy, which is the romantic white tea. So I was on this white tea and magnolia, guys. So that's finishing up. And I only had a little bit in there, so that's why I'm like pouring a whole bottle in there. So So I'm gonna wash that probably on 12. I'm gonna do 8. All right, so I'm gonna take this. Now I'm recycling, guys. So I'm gonna put this in the recycle bin. Be right back. Tomorrow is garbage day, so I'm gonna take this to the road now. All right, guys. So I'm back. Goodness. Over here on my big toe. All right. So I'm about to get my clothes out the dryer. It's always good to make sure you guys change this thing right here. Make sure you change it. So I got a load going now. And then I'm gonna put that in the dryer. And after that, I'm gonna wash my clothes for the bed. All right. So it's a little chilly inside my house. I'm about to go and wash my clothes. Well, I already put my clothes in the washing machine. Sorry about that, guys. I'm about to go and fold my clothes now. All right, guys. So I have a lot of clothes to fold. And also, guys, I did not make my bed this morning. I did not make my bed this morning. So I'm gonna have to make my bed, y'all, because I don't want to be a dirty woman. Look at all these clothes back here, y'all. All these clothes I gotta fold. And I'm about to sit down here and fold all these clothes. So you guys gonna join me while I do that. All right, guys. So I am back. I'll wash my hands. One moment. Let me see where I am now. I'm going to sit down and fold the clothes. And these are a lot of clothes, as you guys can see. Okay. All right. So, can you guys see there? Okay. All right. Okay. All right, guys. So I'm going to be sitting down right here and folding all these clothes. All right. These are a lot of clothes to fold. I got all these clothes right here to fold, guys. But I'm going to fold them. All right. And then after I fold them, I'm going to go get something to eat. Okay. One thing about me, guys, is I don't like to fold clothes, as you guys can see. So basically, like when it's time to wash clothes, I kind of like wash them all at like one time. But I do not like to wash clothes. But of course, it's necessary. But I don't know. My prayer is that God help me to be wealthy and rich, and then I can hire a maid, and then my maids can wash my clothes and dry my clothes for me. So that's what I'm praying, that God will help me to get wealthy and rich. I can have somebody come in and cook for me, and I can have somebody clean for me. I can have somebody wash my clothes, put them up for me. So I got a lot of studying to do, but I'm studying because I don't mind having some maids in my house cleaning and cooking for me. And I'll pay them good too. So that's my prayer, y'all. Maybe my husband will be wealthy and rich. So I'm praying for him too. Yeah. So right now I'm just folding my clothes. And I said, guys, I'm going to put my dirty clothes outside. So I'm not going to have any more dirty clothes inside my house. So as you guys can see, that I got the shed outside. So what I'm going to do is that once my clothes are dirty, I'm gonna take them outside because I don't want any more dirty clothes in the house. So that's what I'm gonna be practicing, y'all. Dirty clothes outside. Now, of course, I am gonna have a bin inside the house. What I'm gonna do is basically just put the dirty clothes in the bin, and then after I put the dirty clothes in the bin, I'm going to take them outside, and I always have an empty bin inside my house. That's what I'm gonna start practicing, guys. So I'm excited. I'm so excited. So I'm gonna get fold of my clothes, and I'll be back. So I am a little hungry. So I'm thinking that for lunch, I'm probably gonna have, if it's God's will, because I'm gonna probably pray for like an hour today. And so I'm gonna pray. I'm gonna pray. So I gotta find out what time I'm gonna be praying. I have two sons, Micah and Keon. And I tell you, they're growing so fast. I'm gonna need to go and buy some more clothes for them. One website that I've been going on to buy them clothes it's called Shein. It's SHEIN. And so I've been going to that website, and I'm gonna go there again, and I'm gonna get them some clothes. So that's what I'm gonna do. All right, this is a beautiful dress here. I love it. All right, this shirt right here that I got, it is a little holy in it. It's a little holy, but I really like it, so I keep it. I think I got it like from probably a thrift store. And these right here, these are my son's shorts. This is a size, my son, this is a size 8. Michael wears size 8, and his brother, Keon, he wears about a size 12. But pretty soon, I'm gonna have to start, this is their socks. I'm gonna have to start getting a size 10 for Micah, and a size 12 is probably still good for Keon because Keon's 11. So, and this is my flowery shirt right here. I like this shirt. I got this shirt from Walmart. It's still a little stretched, but it's okay. All right, guys. So I got one bin completed. Hooray! I am happy about that. All right, so now I got one more bin, y'all. Oh, Jesus, I hope you don't crucify me, guys. Look at this. Oh, these clothes. Look at these clothes, girl. All these clothes I gotta fold up. All right. Roar! Roar! My son likes dinosaurs. All right, guys. Okay. I'm gonna get the folding. Whew. All right, so these are Micah's shorts. He wears size 8. And once again, that's my youngest son, Micah. All right, this is a Born to Lead shirt. This is 6'7", so that's too small for him. So I'm going to donate this shirt. So I'm going to put that over there. I'm going to put it over to my right so I can donate it to those who are poor. So any clothes that are too small, instead of just throwing them in a trash can, I'm just going to donate it. All right, so over here, this is a dress. I like to wear these dresses when I go to church. So I'm probably going to, when I wear dresses, when I go to church and I wear a dress, I like to like put it on a hanger. So these clothes here, like if you see me with a dress like this right here and like this, I'm just going to put it right there because that means I'm putting it on a hanger. All right, this shirt here, this is Micah's shirt. It's probably too small. Yep, this is size 7. So that's probably going to go to donations for the poor. Okay. All right, so this is going to go to donation for the poor. This one here, this is Micah's. This is size 10. I think this is probably Keon's. Yeah, I think this is Keon's. It's a size 10 because Micah's a size 8. But Keon should probably be a size 12. Well, these are Keon's right there. Those are probably going to have to, I know Keon's growing really fast. Let's see. Yep. I think this is Micah's. This is the 8. Those probably Micah's too. I know this is Micah because I remember he had like these eyes. I picked him up from school one day. I remember those glasses. I remember that dog too. All right, so I'm gonna put his shirt right here. Put that right there. All right. So next, this shirt here. I remember I was preparing to go to the Bahamas. I had bought all my kids like some Bahama clothes. This is Micah's shirt right here. So I'm gonna put that right there. All right, this is Micah's shirt too, but I think this is a size 7. Yeah, that's too small now. We went to the Bahamas for Christmas last year. So I was actually trying to go to the Bahamas this year. I was thinking about going for July. And so I was thinking about going like for summer. But we probably just have to go maybe Thanksgiving, or because my schedule right now, because I'm a registered nursing student, is like very, very, it's like, our teacher is she wants us to be the best. Well, she just doesn't want us to miss a day. She doesn't want us to miss anything. So we'll probably go maybe for October. These are Micah's too. Maybe for like October or November or December. So I'll have to ask. These are Micah's too. These are some shorts I got. They say King on the side. That was from Shein. Shein has lovely clothes, guys. I'm telling you, if you have not shopped at Shein before, shop at Shein. They are really, really good. All right, so this sock here. Oh, we went to this place called Sky Zone. And when you Sky Zone is basically like a trampoline place where you can take the kids and they can have fun with other kids. So yeah. All right. So then we got hot sauce socks. All right. And this one is Keon's. It's the 11 to 12, so I know that's Keon. And it's a shirt because I want him to learn how to praise the Lord. All right. That shirt is Keon's. So we'll put that right there. And then this shirt right here is Micah's. All right, guys, just want to tell you a testimony. If you have children, do not allow them to have snacks before they go to bed. Because if they have any snacks before they go to bed and it's like any little bits of crumb, I'm telling you, it's a possibility. You never know. So before, like if a kid, after you give them their bath, they get ready to go to sleep, no sweets, no snacks, so the children can stay safe. I'm telling you guys. Don't allow them to have any snacks. You don't want any snacks or anything on them. That's how they get to stay safe. This shirt is, this is Micah's shirt. It says, "Find your power." All right, that one says, "Find your power." This shirt here is Micah's again. It says, "Out of this world." I got this shirt probably from Walmart. I love Walmart, y'all. I love Shein, but I like Walmart too. These shorts here, they're kind of big. Oh, these are Micah's. These are a size 8. But I gotta start buying Micah clothes in like a size 10. And this is my shirt, y'all. I used to study. I still kind of study with him. It's been some time since I studied with him. But if you guys have ever seen YouTube, there's like this gentleman. His name is Ari Haresh. And he has a channel where he's like, he does 50-minute 10. So like 12 hours, 10 hours, 8 hours. And he has his own apparel. So I bought this from his channel because he encourages me to study. So I really like that. This one here, this is Keon's 10 to 12. Keon Puma shorts. Keon lives with his dad and his stepmom. He's doing homeschool now, but I'm thinking, I got to talk to his dad about it, but we'll see what happens. You never know. He loves his dad and he loves his sister. He loves his family. His family is such a big support in his life. Very grateful for his family. All right, this is a Puma 10 through 12. So that's Keon's. It's Keon's shorts. Well, it's actually pants. All right, this here is I'm probably gonna go to donation. 6 through 7 is too small, so I'm gonna give it to the poor. I had an opportunity to go to clinicals this week. And when I went to clinicals this week, I was able to help the poor, give them clothes, help feed them. I was able to see how the Daily Bread gives them like shirts and clothes and like things that they need. So I can actually take those clothes over to the Daily Bread. I think it's kind of like for adults, but maybe sometimes the adults have children. So I'll probably take those over to the Daily Bread. This is 10 through 12. These are pajama pants. So these are Keon's. These are Keon's. All right. All right. So these here, these are size 8. These are Micah's. Okay, size 8. Let me give that to Mike. Those are Micah's. All right, these pins here, these are size 8. So I give these over to Micah. These are Micah's. All right. This is mine. All right, pardon me, guys. All right. All right, this one right here is, let's see, this is 10 to 12, so that's Keon's. Ten to 12, it's Keon's. All right, this one's right here. All right, this is mine. This right here is a turtleneck shirt. Sometimes I like to wear like the long sleeve shirts so I can stay cool, so I can be warm. All right, so this is my turtleneck shirt here because I don't want to be cold. All right. Next, this is my next shirt here. All right. Okay. All right. Next. Oh goodness, y'all, I'm getting somewhere. All right. So sometimes I like to wear these on my head. So you just kind of put it on like that. Make sure it's aligned. And sometimes I'll wear these on my head. You gotta turn it over just a little bit. But I really like these. These are called a hibachi. So you put them on your head. It's like a head covering. And I really like them. So sometimes when I go to church, I'll wear these. All right. So next, these shorts here are Micah shorts. These are a size 7. They're probably going to be donated because they're probably too small, but you might be able to wear them just a little bit more. All right, this is a blue dress that I wear to church. And remember I said like my blue dresses, I'm going to be putting them over here so I can hang them on a shirt, hang them on a hanger. All right. Okay, guys. Almost done. Thank you so much, guys, for watching because you guys really helped me, encourage me to do better and to make sure things are completed. So thank you guys so much for watching today. All right. Don't forget to like my channel and subscribe. All right. That's what my son says. He's like, he has so many subscribers. I'm like, well, mommy has only a couple. All right, guys. So this here is another shirt that I got. I don't know if you guys can see it, but on the front of it is a lion. And Ari Haresh has basically an apparel, and it's called, his channel is Study Lion. So he encourages the lions to study. So one of the, my son, his middle name is Judah. And the reason why I named him Judah is because Judah is like praise. It's a lion who praises the Lord. And so when I seen Ari Haresh, I was like, wow, it's a lion who actually studies. So he's encouraging the lions to, not just praise the Lord, but to also study. So I thought that was amazing. So I supported his apparel. These are my sons. It's 10 through 12. It's Adidas. And my oldest son, Keon. All right, next. All right, once again, guys, I told you I like turtlenecks. So this is my next turtleneck that I got. All right. These things they're really nice because they make your outfit look really nice when you wear them. So I like that. All right. So I got that one there. And then I got this outfit here. I think I got this from Shein too. You know, sometimes people ask you questions like, where did you get your clothes from? And so sometimes it's good to actually go through your clothes and actually give yourself remembrance of where you got your clothes from. So I think I got this from Shein, y'all. So if anybody asks me, I'll be able to identify. These are the best for the mommies. These little these long nightgowns. These are the best. They're so comfortable and soft. I love them, y'all. All right, so I got my little nightgown there. Okay, and I got this dress here. This dress that I got right here. It's a very lovely dress. I think I got this from probably, I have to see where I got this dress from, y'all. But it's a beautiful dress. I probably could put those two together and wear it. I think it's really nice. All right. So here's another one of my shirts, y'all. Thank you guys for being so patient with me. I really appreciate it. And I pray that God bless y'all with honor and that God will just do something wonderful in your lives today. This is my other son's shirt, Micah. This is a well shirt. It's a well, that's a piece of paper on the side. All right. Okay, here's one of my this is one of my nursing jackets. All right. All right, so next, here goes another one of my dresses. And that's going to be put on a hanger. Then I think I went to Target one day, and when I went to Target, I seen this shirt. It says Seminole, Florida State University, right here. So shout out to all those at the Florida State University. So I had purchased this shirt right here. All right. So this is one of my tank tops that I have, and it says, "More weekends, please." I love Fridays, I love Saturdays, and I love Sundays. All right. So this here is my son's shorts. This is Micah's. It's black and gray. All right. So next, this is one of my shirts here. All right. Okay, guys. Almost getting there, y'all. There go another jacket. All right. Okay. Now these are a size 6, and my son is a size 8 now, so I'm going to donate these to those who are in need. These are a size 8, so I'm going to keep these here. They can still fit him. So I'm going to keep these. And this shirt here, I got from Walmart. It says Grandma Life is the best life. I've had some really good grandmas in my life, and they really showed me, like my grandma who was on my dad's side, my grandma who was on my grandma, like, who was married to my granddad. She was really nice. She's still living, praise the Lord. But she was very nice, very soft spoken. She really didn't she was nice. She was nice. And then my other grandma on my mom's side, she was very quiet. I really never got really close to her because she lives in another state. But like, she would always like send us gifts, like earrings, or she'll send us like cards. And like she would come, like, if there's a holiday such as like July 4th, or if there's like Christmas or Thanksgiving, she would visit. So praise the Lord, she's still living as well. And then grandmas are just special. I just love grandma. So when I seen this and said Grandma Life is the best life, I got this shirt because I know that, this is a good life. Don't be ashamed to be a grandma. Don't be ashamed. Be like, oh, I'm getting old. Some people say, oh, I'm getting old. But it's an honor to be a grandma. So I got this shirt. So God bless all the grandmas. All right. And this shirt is Keon's shirt. That's my son's shirt. It says Dynasty Hoops Champions. So I pray that my son will continue to be a champion, that God will bless him with scholarships, may he be a multi-millionaire, may no weapon formed against him prosper. He wants to play in the NBA, y'all. So I pray that God will bless my son, bless his dad, his stepmom, V, his sister, his uncles. May they all be blessed in Jesus' name. So this is my son's shirt right here. And then I got one more dress. The rest are just like undergarments, so I'll get to those later. I'm gonna fold these up, put these in a drawer, put these on hangers. You guys are gonna see me make my bed, and then after that, I'm gonna go get something to eat. So not too much longer, guys. Thank you for your patience. These are my son's pens, Keon. It says King Keon. All right. So I'm all through. The rest are just like undergarments. So I'll get to those last. I'm going to put them in the bin. Get everything in a drawer. Those are clean. All right. All right, so these over here, these are my shirts. I'm putting in my closet. If you guys want to see how I organize my closet, you're more than welcome to. So this is, make sure you guys can see really good. All right, so this is my closet over here. All right, So I got my dresses. I'm gonna hang my dresses up. All right. And guys, you will be surprised when I tell you this. Look what I got in my closet. I have a wedding dress. I have a beautiful, beautiful wedding dress. So, y'all know I'm praying for marriage and I'm praying for a husband. So I brought my dress to get prepared. All right. So now I'm just putting all my clothes. I'm putting all my clothes on hangers. All right. But yes, y'all, when my husband come, like, babe, when he asked me to marry him, I'm not gonna tell him beforehand, unless the Lord tell me to. But like, yeah, babe, I already got my dress. I already know we're either gonna go to Rome, Paris, or Hawaii, or Bora Bora. I'm like, babe, I got everything planned out. I've been praying a long time. All right, so looking for some hangers, y'all. So I got this dress here. All right. So the rest of my clothes, y'all, I'm going to be putting in my drawer. So the front gonna be like my pajama shirts. Over here have like socks and things like that. So I'm gonna put these over here. My socks. Hope you guys can see. All right. Make sure you guys can see okay. Let me see. All right. So what I'm doing, these are my drawers. So I'm just putting things in them. All right. These are my work clothes. So those are my pants. These are my shirts. So I'm gonna see how many shirts I can get in there. Probably gonna have just the bottom one too. Yep, these are my shirts. Just put them in there. All right, next, got some pants and skirts. But I'm probably gonna put them over here in this closet. Yeah, I'm gonna put these over here. All right. Okay. All right, gotta put my towels away. My towels are gonna go in my other closet, so you guys can follow me. Cause I'm gonna be putting my putting away my towels. So I got 2 closets in my room, which I really like. So put these over here. There's a lot of space over here, matter of fact. So, and then I got my prophetic, this closet over here, y'all. I gotta add some more stuff. I got some shoes down there. But this wall over here says he said yes. So my husband wants to marry me. I'm like, yes. And then I guess that's a signification that, that he said yes. It used to say she, but now I moved the she and I put the he. Maybe I should put the S back up. I don't know. All right. So I'm going over to my kids' closet now because I have to put their clothes up. So I'm going to show you guys my kids' closet. I got 2 boys right now, but I want to have like 5 or 6 more. Well, like maybe 3 or 4 more kids. So I gotta wait till I get married. All right. So this is my kids' closet, y'all. This is all my kids' closet. You guys can see. I got the clothes here. And we got like puzzles and spelling, mathematics, projects, air rocket, solar system. So this is my kids' closet. So I'm gonna get everything put up here. So let me see how I can do this. I'm probably gonna just do it like that so you guys can see. All right, so this is my kids' closet. I'm putting the pins up. These are size 8, so these are Micah's. Put them right there. I'm gonna get some more clothes. I hope you guys can see. Let's see here. All right, I hope you guys can see okay. All right, so I'm still working on the closet. Be right back. All right. So these are Keon's. I'm gonna put them probably up here. Yeah, they kind of fit. Okay. So, all right, I gotta get some more clothes. I'll be back. Back. So I have some shirts from Micah. I'll put them up here. These are some of his pants. Put them right here. Put these up here. All right. Okay, so let's see if I got anything else. Okay, so I got some socks. And I'm gonna put the socks down there. These are Keon shirts. Put that right there. And this is Keon's pajama pants when he comes over. And this is a Sky Zone sock. All right. So now I'm gonna go back to my room because I need to make my bed. I've been streaming for like 6 hours now. Hopefully I get to 12 soon. All right. All right. So now I'm going to make my bed. And I don't got any hangers, so I'm gonna have to fold this blue dress up. Just gotta get some hangers. I love this jacket, y'all. It's one of my favorite jackets. You put this on, you just get the anointing. Just like this jacket. Probably leave it on for a second. All right. Then let's go there. These are my undergarments. So just excuse me. All right. Actually go right here. All right. So these, my study apparel. Put that down there. I love to collect pins, y'all. So put that over there. All right, these are clothes I'm going to be donating. Okay, all right, time to make my bed. Okay, so you guys seeing I got some more coming soon. Some more clothes that's gonna be washing. Those are I love silk. Oh my goodness, I love silk, especially white silk. I love white silk. When I was a little girl, my grandfather, he was in the army, and so he had like these things. They were called puncho liners. And a puncho liner is basically, it's like a silk material that kind of like keeps you in like a good temperature. And oh my goodness, as a little girl, I would just wrap the puncho liner all around me, and I'll put my my finger in my mouth, and I would just praise the Lord, and I just feel like I knew that God was protecting me. And so I still have that today. Still have my the desire, actually not a need, but the desire to be covered with silk. There's something about it. So if they had a silk comforter, I would get a silk comforter. But right now I have the they probably gotta do. I just gotta save up for it. Whew. All right. So, and guys, please excuse me. I have one silver pillowcase, okay, and I got one white pillowcase. So that's because I gotta do washing. But what's good is that, guess what? My deer on my pillow, they're the same color as the pillowcase, so it kind of matches a little bit. But if you're wondering, why does she have one silver pillowcase and then one white one? Well, that's why, y'all. I gotta do some washing. All right. So I'm putting this back over here. All right. Okay, so I'm putting my iron up. Y'all, what is it with irons? I think I need to get me like a new iron or something. One that takes out all the wrinkles without having to go to the cleaner. All right. So these are going to be donated. So this is my ironing board here, y'all. I think about 2 or 3 years ago, a wise man who loved the Lord asked me, "Do you want an ironing board?" Now I could have said, "No, I don't want an ironing board." But when a man of God asks you if you want something, I said, "Well, this must be symbolic that Lord is delivering me from, my wrinkles and my blemishes and my spots." So I said, "Yeah." So every time I always iron with this ironing board, and I know that God is delivering me from spots, from wrinkles, and from blemishes every time I iron on this ironing board. So shout out to him, y'all. May he live to be 102. In Jesus' name. All right. So thank you guys. I'm about to go and put the clothes in the dryer. Thank you guys for checking out my channel today. I'll be back studying probably maybe in about 2 to 3 hours. So I'll make another video. But don't forget to check out Woon Jin Chao. Don't forget to study, read, and may God just deliver you guys and make you whole. In Jesus' name. Bye, guys. See you later.